Should I stand here? Is that right? Okay. All right, good morning, everyone. Thank you so much for having us on the program. To the organizers, we're thrilled to be here. Very first time out on the slope. I want to thank Joe for discussing this paper, despite the fact that Robert and Ezra were running things in Berlin up to the last minute. And I want to also introduce my German colleagues, Robert and Ezra, who are sitting there. All right, so the title is Demographic Shocks and Healthcare Spillover Effects of the Refugee Crisis on Germany's Aging Population. Is someone keeping time for me? Okay, perfect. So our broad motivation is that we're living through a time of multiple refugee crises. According to UNHCR, 1 in 70 people approximately on the planet are forced to flee. That breaks down into over 40 million refugees, 70 million approximately displaced people, and 9 million asylum seekers. Now, these numbers have been increasing over the last 2 decades due to climate change, due to conflict, due to climate change-induced conflict, all of the like. We're going to be focusing in on the Syrian refugee crisis, which was precipitated by the Syrian civil war and led to the largest refugee influx in Europe since World War II. So you can see these are different countries. This was put together by RF Berlin. Germany is black, and you can see that they accepted, about 1 million asylum seekers over that time. That was unprecedented up until, of course, the most recent Russian invasion of Ukraine and a huge increase in German refugees from Ukraine. You can also see it in the number of asylum applications to Europe, peaking again in 2015 and then more recently with the Russian crisis. And then a very long series from Germany showing this 2015 to 2016 peak. So I'm sure you remember the headlines and the boats, the photographs of people in boats and children on beaches and all of that horribleness. And in the midst of that humanitarian crisis, Angela Merkel did something quite heroic in that she suspended the Dublin Convention and let about 1 million asylum seekers from Syria and Afghan and Iraq come in. And to the country winning a refugee award recently with the phrase, "Wir schaffen das," we will manage, kind of a famous phrase at the time. Now, other people have explored this shock. In the public health literature, there seems to be a lot of commentary about the unmet needs, healthcare needs, mental health needs of the refugee population. With the same set of co-authors, we have a paper under review on, how the refugee utilization converged to native-born utilization. There's a nice paper in the Journal of Political Economy from a Harvard econ grad recently who looked at the social integration of these refugees using Facebook data. And then my illustrious discussant, Joe, has a very neat paper kind of in Denmark, a neighboring country, looking at the effects of places that refugees were kind of allocated to. That's a similar approach that we're going to use by state rules, looking at how those places affected the children and how it affected their long-run employment and earnings. But the fact of the matter is, when you have this sort of large influx of individuals, this obviously has fiscal repercussions for the state, and that actually, there's a lot of headlines associated with that. And so we're kind of sitting at the intersection of refugee policy and social insurance. So there's quite a lot of discussion of how, immigration and refugees, who are generally the poorest and most destitute and desperate of immigrants, affect labor market competition, and how they affect the culture and whether they wear a headscarf and whatnot. But there's also a huge implication for pressure on publicly financed services such as housing, education, and healthcare. And there's a concern that it will reduce quality for existing residents. Obviously, healthcare is an ideal setting to look at this. Healthcare is a large part of most European countries and other welfare states. It's about 12.5% of German GDP, $9,000 per capita. And ink has been spilled on this question as well. How high are the healthcare costs for refugees? Are refugees considered more equal than other Germans? And again, their healthcare costs incurred by asylum seekers, placing a burden on municipalities. So we wanted to actually explore this empirically and understand in the context of a universal healthcare system, which received this incredible expansion in demand, how did this government system cope? And in particular, it has some rules about publicly administered healthcare supply and whether these sort of automatic stabilizers, if you will, were sufficient to handle this 1% increase in the German population. We also think we fit into the health insurance literature more broadly because we all know about, we all teach the RAND experiment, the Oregon experiment, the expansion of the ACA, but we're generally looking at how, when we expand insurance, how that affects the people that received that insurance. The focus on the targeted patients, and we want to look at those who are incumbent to the system already. And again, in all of those instances, we don't have a coordinated sort of public supply response as we do in the German context. Okay, so we're going to explore this huge, massive influx that created this large demand shock. We're going to examine the spillover effects on healthcare utilization and outcomes of the elderly host population, and we're going to look at it within the context of a universal healthcare system that doesn't just do public financing, but it does public administration. To do so, we're going to exploit the random variation of refugee allocation using the state level. Robert and Ezra, do you want to pronounce this word for me? Thank you, that thing. I will call it the KS rule, which allocated refugees across various states, and we're going to combine that with a distance-based instrument. And we have a multi-stage instrument that we're going to construct from this distance and this allocation rule. And what we'll find, and these findings are preliminary, I should say, is that higher refugee exposure reduces outpatient costs, increases acute care usage in the short run without an effect on mortality, but these results attenuate over time and are driven by counties that were GP supply constrained. Okay, so let me tell you a little bit about the German healthcare system. It has universal coverage. About 89% of the population, including welfare recipients and refugees, are covered by statutory health insurance. About 10% are privately insured, and less than 0.1% are uninsured. In contrast to the actuarial principle, in Germany it's the solidarity principle. So insured individuals contribute the same share of income, so it's not progressive in particular in that regard, but the benefits are according to their health need. There's competition amongst these nonprofit sickness funds, but patients themselves face no restrictions on choosing among about 1,850 hospitals and over 190,000 doctors and therapists. Nearly all providers contract with statutory insurance, so not like Medicaid, where some people don't take that type of insurance. Co-payments are generally low and uniform. And there are no formal access barriers between insured groups. So refugees and elderly Germans are going to be drawing on the same pool of providers. What about the refugee allocation in Germany? This is important for us because it's going to be a source of our identifying variation. As I mentioned, Germany absorbed more refugees than any other high-income host nation, unprecedented size and scope. The refugees were first allocated across 16 federal states using that KS rule, and the allocation rates were based on historical tax revenue and population counts. So you can see that here. You can see Bavaria and Baden received 15 and 13%, and a large share also went to Westphalia based on those rules. Within state, across counties, that was really determined by the available reception capacity. And so this was, I think you can understand, was a very rushed attempt to find accommodation for this 1% of the population that influxed in. Many refugees were housed in former military barracks, sports halls, hotel. Actually, they called container villages because they were shipping containers, et cetera, et cetera. And so we're going to be able to compute the distribution across counties and give you just a map of that. You can see again Westphalia and Bavaria kind of lighting up here, corresponding to the rule. And we're also going to be able to look at all of these initial refugee accommodation locations. I'll show you a map of that in a minute. The big data set that we'll be using here is the longitudinal AOK claims data from 2014 to 2019. AOK is actually an abbreviation for this word, which I will not attempt, but it's Germany's largest statutory group of health insurance funds. It covers about a third of the overall German population, or 27 million lives. And you should think of it as the traditional catch-all community insurer. AOK members are generally older, poorer, and sicker than the German average. Why refugees end up in AOK is that upon arrival, asylum seekers' healthcare is administered by municipal welfare offices, which generally delegate them to this community insurer as the contracted local fund. And then once they become eligible for statutory insurance, they generally just default into what they were placed into previously. So a very large share of refugees end up in AOK post-2015. Relevant for our project here, we're going to have the two vulnerable populations of interest in our data. We're going to have the refugees, and we're going to have sort of the sickest and poorest elderly Germans. Okay, I should say that right now we only have 132 counties. We were able to ask AOK, and Robert is an employee of AOK, on faith to please give us counties, and we asked for counties that had more versus less refugee share so that we would have some good variation to show you today. Our hope is that we knock it out of the park, and they are so excited to work with us that they give us all 400 counties, so fingers crossed. But in addition, we're going to do population health metrics. We can do at the county level comorbidity indices. These are analogous to the Charleston Comorbidity Index we use here in the US, county level age and female share. From the Federal Statistical Office of Germany, we're going to have official counts of the refugee population in country, state, and by county. From the INCAR database, which has maps of spatial and urban development, we're going to have pre-refugee influx, so 2014, we're going to have the age distribution, sex distribution, immigrant share. Also, we're going to have be able to control for mean education, university attendance, median income, whether the county was considered urbanized, the unemployment rate. And finally, we'll have detailed information on area healthcare resources, such as hospital beds, GPs, nursing beds, and staff per population. And the thing we had to really work at, and we're still working on, is the refugee accommodations. These are the container ships, the barracks, et cetera. We scraped these data on location, and we will use this to compute the distance between each GP office and the closest refugee accommodation center. So these are all of the data points you can see here. Again, in Westphalia and in Bavaria, there's more. Okay, so our study populations, you can think of these on the left-hand side. These are going to be elderly, German-born AOK insurees, about 1.4 million in our data that are 65 plus. I think given what I've told you about being this sort of community catch-all insurer, you can think about perhaps the effects that we're getting are an upper bound because these are some of the most vulnerable German citizens. And then we think we have the pretty much the universe of the right-hand side here, conditional on not having all counties yet. And we're able to identify refugees as those who are Syrian, Iraqi, or Afghan nationals who enroll in AOK post-2014. Obviously, our key identification challenge is that refugees do not randomly sort into physician practices, and we think that they're potentially likely to access physicians that treat, lower SES patients. And so we have this, what we call a 3-stage shift share instrument. In the 0 stage, we're going to predict the county-level refugee population using a push-pull interaction, where the state-level KS quota gives us the push, and the presence of refugee housing gives us the pull. We're going to use those residualized coefficient to construct a practice-level refugee share using the county allocation from that 0 stage, and then the distance between the GP and the nearest local refugee accommodation. And then the rest of the mechanics are pretty standard. We're going to predict the practice refugee share since we have that from the claims data, and then we're going to use their elderly patients on the left-hand side to look at their utilization and outcomes. So what this looks like in math, how am I doing on time?
5.5 minutes.
Oh, right, so we don't need math. Okay, so there's the push, there's the pull. Important things is we're going to control linearly for the things that determine the KS rule, the tax, the population, and these county characteristics that I mentioned before. This is how many refugees came into the country, how are they allocated across states, and for right now we're using an indicator about whether there's a refugee accommodation in that county over the total in the state. In future work, we actually hope to also extract the capacity. All right. So this is all fairly standard as well. We've got the second stage. The only thing to note here is in addition to these 0-stage controls, where we have the tax, the population, and county, we're also going to include linearly the distance that we're using to construct the practice level refugee share and some patient and practice controls. Patient controls like age, sex, the risk score, and the practice controls like how many immigrants they saw in 2014. Okay, with that, what are we getting at here? So 2 practices at the same distance receive different projected refugee exposures because they are in counties with different predicted refugee allocations, or 2 practices in the same county will receive a different shock because they are located at different distances from the accommodation. Now, we have a little bit of imbalance at the baseline, but we have 1.4 million observations, and the imbalance overall is actually quite, I would say, economically insignificant. This one, for example, translates into 17 days younger patient on a mean of 77 years old. Slightly higher inpatient costs, about 1%, and slightly higher hospital admissions. This is still a work in progress, but again, all of these are much less than 1% of the sample mean and kind of go in different directions, lower mortality, higher inpatient costs. What do we see when we look at the OLS and the IV? So here we have outpatient, inpatient, and emergency care. So the OLS shows reductions in outpatient care, increases in inpatient care, and increases in emergency care. The 2 SLS show us indeed that we have lower outpatient spending by about 4 to 5%, but higher hospital admissions of 7%, emergency spending of 9.6%, and emergency visits by about 14% relative to the mean in 2016. When we look at ambulatory care sensitive conditions, the OLS shows effects that are positive on both admissions for ambulatory care sensitive conditions and mortality. We do not see, however, the same thing when we look at the IV. So those effects are indeed reversed and probably align with the selection patterns we think might be at play. So when we look at 2017, that was for 2016, we kind of see that same pattern. So outpatient costs and GP costs are going down. Inpatient and acute costs are going up, especially ER visits. But when we actually look at it over time, comparing the 2016 to the 2017, we actually see that in general, almost across the board, except for specialist costs, you can see that things attenuate. So by 2017, relative to the mean, things are actually improving in the German system. And we didn't plot mortality because there was never any mortality effect. Finally, when we look at where these effects are coming from, we actually see that Germany has this rule that there can only be GP physicians up to 110% of what they consider the target GP capacity. And all of our effects on reductions in the outpatient care and increases in acute care, those are all coming from GP-constrained locations. So we've done some robustness tests, and I want to be cognizant of the time, so I'll tell you what our future plans are. We want to obviously expand to all counties. We want to assess the mortality effects for the full German population. We should be able to do that. We want to refine our IV by using capacity and improve our measurement of distance on a finer level. And we have this sort of very, enticing result that it's really in these constrained areas where GPs couldn't move in, where we saw these sort of adverse effects, increases in acute care and reductions in outpatient care. But we really want to make sure that that's actually where the GPs came in to respond. And lastly, and this was something that was talked a lot about, but we haven't been able to look at it carefully yet, is that, not all refugees, many of them were in fact medically trained. So some of them could actually themselves serve to offset some of the demand shock. In conclusion, our main findings are that higher refugee exposure indeed reduced outpatient care and increased acute care among the German elderly, but the effects attenuated over time, even within 2 years, suggesting some system adjustment, and the impacts were concentrated in places that administratively were GP constrained, where slack was limited. And lastly, to date, and we've run, a fair number of specifications at this time, no increase in mortality among the vulnerable AOK elderly, despite what the OLS shows us. Our policy implications suggest that, publicly administered health systems can adjust, but we, again, need to document very carefully exactly how. And lastly, wer schaffen das? I mean, seems so. So it seems that they managed it, fairly well, at least from a mortality perspective. So thank you. Danke.
Morning, everyone. I'm excited to talk about the paper, but Marcella and I help run the MBER Roybal Center for Behavior Change in Health, so we thought this was the ideal opportunity in front of an aging researching group. See, I said that. There's a hyphen there. To get in front of you to call for proposals. So we give out funding for trials of behavioral interventions. Put on your behavioral economist hat. And they're about $260,000 over a one-year trial, so relatively well-funded. We look for things that move health outcomes, ideally aging-related, and the Roybal Center is very keen on uncovering mechanisms of behavior change. So testing, measuring mechanisms is a plus. As economists, we like scalable and cost-effective interventions, of course, and they have to be fully powered trials. And one note of caution is the recruitment cannot begin without a series of bureaucratic NIA approvals, which have taken longer over the past, let's say, 18 months. And so you need to have a project that doesn't have real-time sensitivity. Overall, the process is relatively friendly, but this one hurdle of you have to be able to hurry up and wait a bit. We have a partnership with Geisinger, which is a large health system in Pennsylvania, and they have their own nudge unit led by Chris Chabris and Michelle Mayer, and so they're a great partner. So if you're looking for a site to do an experiment, we have great contacts at Geisinger. So if we're currently have our call for proposals out, letters of interest due in October, proposals due at the end of the year. They're like 5 to 10 page proposals, so it's not like a full-scale R01, yet you still get a good chunk of money. If you have any questions, ask Marcella or me, or you can email Abby Murphy, who helps us run the Roybal Center. And I also have other MBER announcement, one more. The MBER has a couple NAA-funded projects going on. You should check out our website for the P30 and U54 centers on aging, various centers on aging. In fact, there's a conference on October 2nd on long-term care and caregiving, organized by Karina Momertz and Brian McGarry. Their abstracts are due this Friday, so get your abstracts in, and hopefully we'll see you in October. All right. That's the announcement portion of today's service. And now I'd like to jump into the paper, which is on a fascinating topic of the externalities that are associated with influxes of refugees. Marcella as usual, did a fantastic job describing what they're doing, so I won't cover that too much. I found the effects relatively large, lower outpatient spending, higher inpatient spending. In fact, most of my remarks will be about this. Our outpatient and inpatient care, are they substitutes? Can we use this influx as a lever to learn which ones are so? I love that the effects are concentrated in GP-constrained areas. That's a highly policy-relevant result and adds credibility to the overall design. And I also like that in 2017, both of these effects attenuate towards zero in opposite directions. So you'd have to tell relatively complicated endogeneity stories for that to happen. Is the fact that they're both going down is interesting and could help shed light on this substitutability. So let's get to that. I don't think we have great evidence that outpatient care really keeps people out of the inpatient setting. There is certainly lots of research on this. Some of the papers, this is not exhaustive, but some of the papers I like Adrian Savity and others have looked at this really cool experiment in New York City that nudged primary care for undocumented immigrants, and that had a large reduction in ED usage. And it makes sense that if you don't have access to primary care, you may find ED as your refuge. In hotspotting work that I've done among very sick patients targeting superutilizers, the goal of these hotspotting programs is to try to increase outpatient care in order to reduce inpatient care. That's the underlying theory of change, that the outpatient care, you can navigate the system better, you're going to reduce more costly inpatient care. We did find that they increased outpatient care very well, but they did not reduce inpatient care. So there's a bit of a linkage break there. There's lots of papers, I think, that look at how drugs might keep people out of the hospital, certainly cardiac medications and so on. Tim Layton and others have a really nice paper on this from a couple years ago. But the substitution, I think, between outpatient and inpatient care is very intriguing, and I think it's less well established. So what context do we see it, what context don't we, what's driving what? So we've looked at demand shocks in the US, where I know a lot more than I do than Germany. So when Medicaid or health insurance is expanded to low-income individuals in the US, what happens to the elderly? So you have the stock of elderly, what happens to them? And I like this paper's title, it tells you the outcome. In Massachusetts, at least, it did not reduce access among the elderly. And if you look at the lines, red is for Massachusetts, blue is for neighboring states. I kind of defy you to tell me where you would draw the event of the reform. It was in 2007, but I don't think you could tell that from these lines. Similarly, there's a nice paper by Carey and others on expansion of Medicaid to expansion states versus non-expansion states, and their conclusion is that expansions did not impair access to care or utilization of Medicare population. So if you look at their sort of first stage, you see an increase in expansion versus non-expansion states in Medicaid coverage, but you just, again, a kind of flat line on the difference between those states in terms of their primary care usage. So it seems like flat lines are kind of the order of the day here. It's interesting. Some systems adapt quicker than others, maybe. And a related paper from a couple years earlier on Medicaid expansion found, again, that there were modest impacts on Medicare beneficiary spending. Maybe for dual eligibles, they saw a reduction in average spending, but no effects on health outcomes. And I think, obviously, we always want to get to the health outcomes for the ultimate welfare relevance. And then last, Sherry Gleed and Kai Hong have a nice paper that lays out sort of why in multi-payer systems you might have this either cross-subsidization or supply substitution. Once you have more customers coming in from one door, you kind of keep the other guys out a bit. And so they found when insurance expanded, again, among the stock of elderly, they found a reduction in outpatient care similar to what Marcella and her colleagues are finding, but they don't find an increase in inpatient care. They find a reduction in inpatient care. So the point is that these results in the literature are a bit, I would say, small, and they don't usually go toward this substitution between inpatient, outpatient care on a short-term basis. And so we might be able to use this, the German influx story to sort of flesh that out a bit in a different context. I don't know why this is here instead of another place. All right, I'm missing a slide. I don't know why. Let me just jump. Oh, there it is. So when I get into this paper, I have just a few questions that I think would help flesh out the paper. So why are the effects so large in Germany? Marcella mentioned a few differences in the context. One issue is the first stage that they find is a 0.1, then the coefficient. So any kind of lingering endogeneity, you're going to be dividing by 0.1, multiplying by 10. And so that can sometimes lead to larger coefficients, which is also reflected in the standard errors. So again, we should be looking at the standard errors as well. The other part, when we think about where is the variation in this instrument coming from, a broad level issue with shift share instruments from this recent applied econometric literature are the shares kind of exogenous and the influxes are not, or vice versa. Either one is fine, but sort of laying out what do we think is the exogenous story and which is not is important, and it also has implications for how you compute your standard errors. Okay, here we go. So when we think about RC, this is the number of refugees in your county. and we have the push and pull. The push is this weighting parameter, and they're controlling linearly for the things that enter that weighting parameter. So I'm wondering, like, where does the variation in the zero stage come from? A lot of it's going to come from that second term, the multiplication term there, the indicator that you have a refugee base in your county. If you don't, then that whole first term goes away. If you do, it's, are you the only one in the county, or are there many in the county with you? And then when you go to the practice level, you're going to take that predicted, the mu hat times that complicated function, so residualizing out the tax and population shares. You're going to say, well, what share of my practice now has refugees? And that has this distance weighting. When we go to the first stage, you're going to regress that refugee share of your practice on that predicted share, controlling for distance now. So I'm putting all the math up there. Marcella said she didn't have time for the math, so I thought I'd, as an MIT guy, throw in some more math. But you're controlling for the distance, you're controlling for tax and population. What's sort of left in that R hat that's happening? Maybe shutting down a channel and seeing where the results go, shutting down a different channel and seeing where the results go. My sense is that it's mostly coming from that indicator that you have someone, a center in your area. But again, the distance here, it's in the numerator of this, it's in this term, it's there, like how much variation is left and where is it coming from would be really helpful. So to summarize, conditional on distance and quota parameters, what variation is left in the instrument. If it's identification through this sort of nonlinear relationships that are kind of chosen by the authors, I think you need to sort of flesh out exactly where it's coming from. Maybe some figures that sort of trace out the first stage and reduced form along those different dimensions would be really helpful. In terms of outcomes, what are the inpatient conditions that are affected? If there is a substitution in the short run between outpatient care and keeping people out of the hospital, I'd love to know more about like what are those conditions. So maybe we're going to learn more from this paper than the ambulatory sensitive category that we all know and love. And then on exclusion restriction, I think the story at the short run disruption is that the refugees add congestion. So are there impacts on appointment wait times, either in the literature or are there concerns about that? Are there other channels where the influx affects public goods more generally? So you have this influx of people, maybe there's more traffic, more crime, more strains on the daycare services. It could be a million things that these people do, and so is it mostly on the congestion side or not? This, I think, is worthy of a little more, or some discussion. And then last, the reduced form estimates here, the shift share exposure index, you get a coefficient of like 13 on inpatient costs. And if, I think, I may have this wrong, but in the balance characteristics in an analogous regression, the baseline, the 2014 inpatient costs, have a coefficient of 18. So it's actually, the shift share is predicting the baseline measure more than it's predicting the future, the past. It's predicting the past more than the future, which gives me some pause on whether it is balanced. But so the controls now on the patient side are age, sex, and morbidity index. Maybe add the baseline utilization and at least see what happens when you start controlling for that more flexibly. So I'm going to leave you with my call for proposals. Don't forget about the NBER. NBER. No, okay. Thank you very much.
Would you like your slides back?
Oh, yeah, sure, thank you. So, thank you so much, Joe. That was excellent, per usual. I think everything is absolutely great. It is a sort of a nonlinear weighting function that is the KS rule itself, 2/3 tax, 1/3 population. So some of that is still driving the variation. But we certainly could look at, what happens, and we've run those, we just have to pull them out of Berlin when we don't include tax and population, for example, linearly and things like that. I think our estimates are larger because one thing is the first stage is smaller, so we are dividing by something small. But also the shock is quite large, 1% of the population. And yeah, I think we're hoping to get a better first stage as we look at a better distance measure and better capacity. That is that. And actually, yeah, I think mortality in the reduced form kind of goes in an opposite direction to the balanced test. Wonderful, thank you. Any other questions? Yes?
So I'm confused about whether it should be percent I'm confused about whether it should be, like, at the practice level, is it percent or total that matters, right? It seems like a very different experiment to say, I just have a lot more patients in my practice.
That's a great
Then
point.
I shift.
Yeah. So
and
right
this-
now, we're doing we're using the 2014 patients as the base before the influx, and we're looking at the share of those patients that are refugees. But we could also certainly do it as just the level, like the number of refugees. We've normalized it by the patient population
Well,
in
and-
2014.
Just to follow up,
Yeah.
the patients are the patients who were in the practice before the influx?
That's right. Yeah.
Good, because I was concerned that,
Yes, it's the patients in 20, pretty much everything that we control for at the county level too, everything is 2014.
but this might get at the magnitude issue.
Yeah,
right?
yeah, that's true.
It's not percent.
Yes,
It's
it's,
about them getting crowded.
yes, that's right. Thank you.
Could you talk more about the capacity constraints of the physicians and the
Yes.
110%?
Yes.
Because those states or counties at the 110% level actually have more physicians, right? And is that just because the doctors want to live in those regions? And also, how does that vary across inpatient, outpatient, emergency care?
These are all with respect to GPs, so these are all,
GPs.
this is an outpatient rule that we're discussing. And this is a situation where they're at the limit, so unless they change the rule, which has been in place in 2012, which they didn't over the time period of our analysis, no more GPs can enter to care for those patients. And what I know anecdotally from talking to my German colleagues, but we need to do this, in a data-driven fashion, is that indeed there's sort of like a pent-up supply of physicians who are working in hospitals that want to go into the outpatient and set up their own practice, and they can't because of this quota. So we presume that that's what happened in these places that were not so constrained. Yeah.
So I don't know a ton about German health system, but I thought there was like a pretty hard delineation between inpatient and outpatient care. Like you didn't do both in the same institutions and stuff. Is that right? And does that in some way impact how I should think about the offsets between inpatient and outpatient care?
This is a great question. Let me hand it over to Robert, if that's okay. But I do think that the GPs play important roles in Germany, that they may be a little different than in America. Do you have a mic for Robert? Can someone pass him a mic? He just came in for Berlin, so he's a little jet lagged.
Yes, there's indeed a strict separation between the inpatient and outpatient providers, but in theory, if there's a really large demand which they cannot supply by the outpatient physician, sometimes the hospitals are allowed to provide outpatient care, and that could be a possible channel because it's easier to allow this if there's no capacity constraint for the GPs, because then they're more flexible to allow for other providers to provide this outpatient care as well. So that could be a potential channel, but we still have to look into it.
Over time, they may have just then said, okay, let's open up the inpatient facilities for some of the outpatient care and find a way to deal with it that way.
Yeah, exactly.
In the U.S. context, immigrants are an important part of the long-term care workforce, like both in nursing homes and home health care.
Yeah.
And I'm wondering, and there's lower barriers to entry. You kind of alluded to some of the refugees having, specific training, but I think maybe it takes time for that to happen. But there could be big changes in workforce, especially for this elderly population. And I was wondering if that was relevant in the German context.
That is a very important question and a great comment and something we hope to look into. But you're right, I think it would take a couple of years, and I don't know, it depends on everybody's prior, but my prior was if we were going to see something really terrible happening to these elderly, more vulnerable German natives, we would see it kind of right away. But that's definitely on the agenda. Thank you.
So
So is there any evidence of, say, changing length of outpatient visits or like physician burnout or sort of adjustments on that dimension?
That would be great. I think we would have to look into some survey data on physician attitudes, and also we could look at physician exits. Again, my anecdotal understanding is that more physicians came into the outpatient setting and that we're not so constrained, but it would be interesting to see. Yeah. Yes?
Yeah. I was wondering whether there might have been, especially 2017, some kind
Yeah.
of mobility response, maybe of the younger people, no? Because you have mostly elderly, and so maybe they are less mobile, but working age people might go elsewhere because they don't want to stay in crowded area with many immigrants.
Yep.
And so this also reduce the pressure, no? 1
Yeah.
year after.
Yep, great point. That is another mechanism that we actually did not have on our radar. So people could migrate out of places that received more refugees. I will say that the housing supply in Germany is not very flexible. I think it's very hard to find an apartment or a place to move to. And so I think my prior is that would be a difficult thing for someone that is elderly to do, but it is something we could at least look in the census counts.
Can I ask a question, actually, following up on what Leila was asking?
Yeah.
I could see how it takes time for the more formal labor supply in the
Yes.
healthcare sector, but I was wondering what the market for informal care is like for just assistance in the home. Is there, are the refugees able to work in the spot market?
Yes,
for
in the spot
care?
market. Martin, do you want to say anything about long-term care in Germany? Yes, I saw you there, and I'm going to use you.
I don't know for a fact. I mean, Robert might know this better, but I wonder how there are cultural differences, particularly when we think about the Syrians. So I don't know how prevalent that is. And also, I don't know about the labor force attachment. Have you looked into this? Are they, particular for the Syrian immigrants, that has been a controversial debate. So it may be different for that specific group of immigrants.
I think we have to look at this in the long term, but being in Germany, it was quite hard for the Syrian nurses or other jobs to be certified and qualified in Germany, so I don't think that it would have an impact in the short term, because it took quite some years to certify all the skills they had.
Yep. And when we, in our sort of health services paper, you can see and you can imagine that the majority, though certainly not exclusively, of Syrian refugees were young men. And so that's not, quite the population that typically goes in this type of role. And I think we've also seen that labor force participation of women, Syrian, Muslim women, tends to also be a bit lower, at least initially. And oftentimes when we look at their utilization of the refugees, it's often for maternity care. So they're having children and they're staying at home to tend to those children.
Yeah, as a sort of another long-run effect here, actually Germany was a very welcoming country at the time of the Assad regime destroying lives there, and Assad now is gone, and the question is there a long run, is there an ability, or has there been sort of return to Syria by the people who were then?
It's a great question.
And it seems to me that would be a very interesting thing, because the whole business about distinguishing between refugees who are in danger and people who are economic immigrants and is a very fraught one all over the world these days. And
Absolutely, absolutely. And
So
like we,
that would
so
be my
the
suggestion
crises
for
are
the update.
not going away. So in fact, I do believe that there is a policy now to try and rehome the refugees to Syria, and I'll let my colleagues talk about that. And I also think, we do have the word demography in our title. I did not include the slides that showed, how Germany is really an aging population, and these refugees were young, and they were having children. And so I think that's an important component. I don't, from what I know of the biography of Angela Merkel, she wasn't just thinking on humanitarian grounds when she made this policy to increase their population by 1%. But Robert, the official stance on sending Syrians back to Syria?
There's a lot of discussion going on about incentivizing the return to Syria, but it's only started after the overthrow of the Assad regime like 2 years ago. And I think there's still very few Syrians returning, so the majority is still remaining in the country. Huh? Yeah, a couple of thousand, yeah.
Thanks, Ezra. Yes? Oh, thank you.
Why can't you simply look at hospitalization of the refugees themselves over time dynamically? So, as you said, it was mostly males, single males who came in.
Yes.
They were not allowed to work, so they had a lot of time. But
Yes.
it's interesting to see the
Yes. We do want to do that. We want to look at refugees' outpatient care utilization. So thank you for flagging that. Yes, absolutely. And our sort of, our paper that's currently under review does that at least descriptively, but we haven't used we have to obviously kind of, we're not going to have the instrument that we have now in order to look at that.
Just one more. So we observe the refugees once they enter our camp, so they are allowed to work once we see them. So they are sort of integrated.
upon arrival, they were initially upon arrival, they were
They don't have statutory health insurance once they arrive, at least for the first 3 or 6 months. So we don't observe that period. We observe once they enter. Yeah.
Fantastic presentation, discussion to start us off today. We are right on time then for going to our 10-minute break. We're going to come back where we continue looking at how healthcare systems adjust and all that by looking at clinical trials and trial participation.
Thank
See you
you.
in 10 minutes.
Hi, thanks. So I'm grateful to be here and have the chance to tell you about this work on how trials avoid high-risk patients and underestimate drug harms. This work is joint with Jason Abeluk at Yale, there you are, and Sachin Shah from Mass General. So RCTs are the gold standard for evidence in clinical medicine, and crucial decisions of both clinicians and regulators like the FDA depend on RCTs as the primary evidence base for judging drug safety and efficacy. And it won't be a surprise to you when I say that trials, there have been longstanding questions about the external validity of the results that we get from trials, in particular when trial enrollees differ from the patients who ultimately take up the treatment, the findings might not generalize from the trial to the target population. And yet there's been limited regulatory attention to clinical dimensions of representativeness. FDA efforts have focused largely on demographic dimensions of representation, especially age and sex, but treatment effects are arguably more closely tied to comorbidities and frailty in many cases. We're going to investigate this question in the context of cancer drug trials, and in particular looking at the external validity of the treatment effects of the drugs for serious adverse event harms. This is a high-stakes setting because cancer drugs often have toxic serious adverse events, which can cause patients to discontinue treatment early and thus not get the therapeutic benefit, or they can cause real harms like organ failure and premature death. Both patients and doctors cite safety and tolerability concerns as reasons why they may stop or forego treatment. Survey data of patients actively enrolled in cancer drug trials say that they wouldn't find it worthwhile to take the drug for 6 months to get 2 months of additional life expectancy because of these concerns. And safety information about new drugs is often incomplete at the time of FDA approval. Roughly a third of new therapies approved between 2001 and 2010 had a subsequent post-market FDA safety event, like a added warning or even withdrawal from the market, suggesting that the trials that we have as evidentiary base may not be revealing all of the decision-relevant information about the safety profile of these drugs. So in this project, we're going to do 4 things. First, we're going to try to estimate heterogeneity in the induced harms that cancer drugs have for patients using linked data from the SEER cancer registries with Medicare claims. And we're going to show that patients' comorbidities and frailty systematically predict variation in drug-induced serious adverse event hospitalizations. Once we show that there is this important treatment effect heterogeneity, we can then ask whether trial participants look different on these dimensions than the target population for the drug. And we're going to show that patients 1 standard deviation higher risk for a drug-induced serious adverse event are 41% less likely to participate in a trial. So there's an important margin of selection into trials. We can use those estimates to quantify how big the external validity problem is in this case. And we find that treatment effects for serious adverse events in the target population are probably about 14% larger than among trial participants. This is among patients age 65 and over. And then at the end, we consider, are there ways that policymakers could consider regulating this? And if so, could there be unintended consequences? Our results empirical section speaks to the external validity of the adverse event harms that drugs can induce. Our data and variation are not well suited to estimating heterogeneity in the benefits of treatment. So we're going to use a little bit of theory at the end to try to think about whether, if there was policy just targeting representativeness for adverse event harms, could that kind of backfire and make the trials less representative of the net benefits if we consider treatments and harms together. So we'll come back to that idea at the end. Okay. So we're not the first people to kind of worry about what sometimes gets called an efficacy effectiveness gap, or a difference between trial results and real world impact. There has been some prior work kind of trying to identify whether trials are representative along various margins, but it suffered from kind of serious kind of data and empirical limitations. So sometimes it'll focus on baseline risk without connecting that to treatment effects. Or there's a lot of trouble with consistency in how we ascertain adverse events in trials versus the target population. So it makes it hard to compare those apples to apples, or we're just reliant on very small samples for these types of comparisons. Mansky argues that external validity is especially consequential in clinical contexts when treatment effects are presumed to be heterogeneous. There's very few treatments in medicine that we would just recommend across the board to everybody. So there's a presumption of treatment effect heterogeneity, which makes this external validity question particularly relevant in this context. And we know that representation in trials might have broader consequences from work, including from Marcel Elsan, that it could shape drug development incentives, patients' trust of the drug, and uptake. So those are all downstream of what we're talking about, but I think it just raises the stakes. So I'm thinking hard about this question of how do we get the right people enrolled. The biostatistics literature has thought quite a lot about what they call transportability analysis, ways of reweighting trials to make them more similar to target populations. In our context, we find both that trials are not collecting or reporting data on the types of variables you would need to kind of conduct this analysis. Second, there's limited overlapping support between the trial population and the target population. So both of those kind of limit the applicability of those methods in the context that we're studying. Okay. So first I'm going to tell you a little bit about how we estimate this heterogeneity in serious adverse event harms of new cancer drugs. So we're using a sample of patients who are in the SEER cancer registry data, and we have their Medicare claims. They're age 65 plus, and they were diagnosed with cancer between 2014 and 2020. For the first analysis, we're going to limit to patients who initiate a cancer drug treatment within 3 to 6 months of diagnosis so that we can use staggered event timing of the beginning drug treatment to try to identify the spike in adverse events that happen at that time. Our adverse event outcome is an inpatient hospitalization with primary diagnosis corresponding to a potential serious adverse event. There's a wide range of these, and they're not always specific to cancer treatment, which is why we use the kind of staggered D&D to separate the kind of baseline risk from the bump that you get when you initiate treatment. And we have relatively rich predictors of what might drive a patient to be more at risk of these adverse events, including chronic conditions, the frailty index predicted from their claims, age, and sex. Okay. So this is a kind of first event study graph showing that when patients initiate treatment with a cancer drug for the first time, they have a pretty large and immediate spike in the monthly rate of serious adverse events. Treatment initiation increases that monthly serious adverse event risk by 250% from a baseline rate of about 1% per month. But what we're really interested in is whether that bump that we see varies across patients. If it's the same for everybody, then it doesn't matter who you enroll in the trial, you're going to get the right answer about the average adverse event effect. So we want to now tackle whether there's heterogeneity in this effect across patients, and we do that in 2 steps. First, we estimate patients' risk of having a serious adverse event just using a pretty simple lasso regression. The outcome is, did you have a serious adverse event? On the right-hand side, we put the patient's comorbidities, frailty index, demographics, and we control for what type of cancer the patient has. We do that kind of in a jackknife way, excluding the index patient from the construction of their risk measure, and then we take that risk measure and see whether it predicts heterogeneity in the treatment effect of initiating a new cancer drug. So we interact our treatment variable with that risk measure to see whether patients who we predict have higher risk have larger increases in their serious adverse event effects when they initiate treatment. We control for group fixed effects, which are defined by the timing at which you initiate treatment, for calendar time fixed effects, for the patient's type of cancer and their risk measure uninteracted with treatment. We are using a kind of imputation DID estimator to compare treated patients to not yet treated patients. So our sample is limited to those who initiate treatment in that 3 to 6 month window. And what we find here, this is a bin scatter plot where the x-axis is showing the patient's predicted risk of a serious adverse event, and the y-axis is showing the kind of individual estimate of treatment effect, which is the patient's actual outcome minus their imputed effect based on their kind of fixed effects and control variables. And we find that patients who the lasso suggests they are likely to have a serious adverse event actually have a bigger bump in their serious adverse events when they initiate treatment. Patients with 1 standard deviation higher SAE risk have a 0.8 percentage point larger monthly treatment effect. So almost kind of double that monthly treatment effect. You can see that the increase in serious adverse events ranges from about 1% per month rate to about a 4% per month rate. I guess a percentage point increase in your monthly rate of an adverse event when you initiate treatment. So there's a fair amount of heterogeneity. We can systematically predict it with patient covariates. Now we want to relate it to trial participation. So for that, we go back to our SEER Medicare data and construct a new co-sample. We identify trial participants by using the National Clinical Trial Identifier that is reported in Medicare claims to bill, because Medicare will pay for some care that is provided through trials as long as this identifier is there. We take those identifiers and look them up in clinicaltrials.gov to identify, was this trial a randomized trial for a cancer drug intervention, and what was the target population for this trial. For each trial, we then identify a cohort of the kind of target population in this year Medicare that matches the target population that the trial describes targeting based on the cancer type. So is it breast cancer or lung cancer, et cetera? The stage, is it early or more advanced stage cancer? The treatment line, is this a first line or second line treatment? And tumor markers, so is this small cell or non-small cell lung cancer? Is this HER2 positive breast cancer or not? So because we have the SEER cancer registry data, we have a lot more detailed information about the type of cancer the patient has that would otherwise be available in Medicare claims, and we leverage that to create these very detailed subcohorts matching as best we can the target population for each of the trials that we include. We have 17 subcohorts. There's one little subtlety that I want to draw your attention to because I think it creates an interesting contrast later. For advanced stage cancers, the target population we identify in these data are patients who are receiving active drug treatment for their cancer. This is because we have information on stage at diagnosis in SEER. We don't directly observe disease progression in the SEER data. So we infer disease progression by if the patient's receiving a drug that's only used for advanced stage cancer, then we're going to say they have an advanced stage cancer. As a result, for our advanced stage cancer cohort, we're comparing trial participants to patients who the patient and the doctor think they're appropriate for active cancer drug treatment. We're not comparing trial participants to a set of patients for whom active treatment would not be consistent with their goals of care, or the patient and the doctor think they're too frail to undergo that treatment. For early stage cancers, we make a different contrast. The target population is just based on having an early stage at diagnosis because drugs are not the current standard of care for many early stage cancers, and therefore we felt it wouldn't be appropriate to kind of say, we're going to compare you to people who are already receiving drug treatment when the majority of these patients are likely not receiving drug treatment. So we're going to look at results for those subsamples at some junctures. When we construct summary statistics, you right away start to see the selection pattern popping out, that on every margin that we look at, trial participants look younger and are less likely to have kind of every comorbidity. This is just a handful, there's a longer list in the paper, than non-participants. That's true when we condition on the type of cancer the patient has. We have data here from 112 trials, and we find that like controlling for the type of cancer the patient has, and after doing Bonferroni correction on the statistical significance, like 15 or 16 out of the 20 comorbidities have statistically significant differences across trial participants and non-participants. Now we want to know what are the implications of those selection patterns for the treatment effects that the trials are going to estimate. So now we're showing you a bin scatter here of the patient's serious adverse event risk that's predicted using that Lasso model, using the patient's comorbidities to predict the likelihood that they're going to have a serious adverse event. That's our x-axis, and our y-axis is the patient a trial participant. And what we see, and this is controlling for the type of cancer the patient has, we see this downward sloping relationship, and it's through the whole distribution of risk. Like, it's not just that trials are avoiding the very highest risk patients, it's kind of working through the whole distribution that the healthiest patients are more likely to be enrolled than the kind of next group of patients. To kind of quantify it a little bit more, patients with one standard deviation higher risk of serious adverse events are 40% less likely to be enrolled in trials. And we have very similar magnitudes if we look only at the advanced stage cancers where everyone's receiving active drug treatment, and early stage cancers where we don't condition on drug treatment. So we have very strong and kind of similar selection across both of those groups. We then compare the distribution of serious adverse event risk for trial participants compared to all patients. Trial participants are the bluer histogram that's kind of with less variance over on the left, and the more spread out gray kernel density is the target populations, and we've reweighted so that we have the same distribution of disease states across both groups. So we have like an apples to apples comparison in the distributions that we're looking at here. We can translate these differences in serious adverse event risk to differences in serious adverse event treatment effects, and we find that the treatment effects in the target population are about 14% larger than the trial effects. So this is taking our model that mapped risk to treatment effects that we estimated in the first half of the talk and using it to understand the implications of this difference in the distribution of serious adverse event risk for differences in the treatment effects that you'd estimate. This corresponds to one additional serious adverse event hospitalization for every 25 treated patient years. And This is, again, just to remind you, this is evidence on selection among the age 65 plus cohort. We have other evidence there's evidence from other papers that patients age 65 plus are underrepresented in cancer trials, so it's possible that the full scope of selection is greater than this estimate because older patients are more likely to experience serious adverse events and older patients are further under-enrolled in trials. But this result is kind of exactly the magnitude you might want if you were thinking about the external validity of subgroup estimates for ages 65 plus, which is how the FDA currently kind of pushes drug companies to report subgroup results in order to consider the safety of the trials for older patients. So we're showing even those subgroup analyses are still not enough to kind of get the externally valid estimate for those older populations. Okay. In the paper, we extend these results. We ask whether fixing demographic representativeness would kind of fix this problem. What if we just got the age distribution right and the sex distribution right or race distribution? And the answer is really no. Most of the selection is conditional on those demographic cells. And so demographics representation is not enough. We ask, how does this arise? Is it from where trials are cited? Or is it within those sites who get selected in? And we find that where trials are cited can explain a little less than a third of the selection pattern that we see, so a lot of it is conditional on being at a particular site. Still, the healthier patients are the ones that are ending up enrolled in trials. And we ask whether the trials that are likely to be pivotal for FDA decisions suffer from similar biases, and about half of the trials in our sample, if I recall correctly, are industry-funded phase 3 trials, and we find very similar patterns of selection in those industry-funded phase 3 trials, which are likely to be pivotal compared to other trials. Okay, so I want to spend the last 5 minutes talking a little bit about regulation and implications of these findings. So I've been talking a lot about adverse events, and I want to remind you that we probably care about net benefits. We care about the benefits of treatment, net of the induced harms, and there's, depending on the delta welfare weight that you put on benefits and harms, you're going to make a decision about whether or not to approve the drug or not, taking maybe some average across subgroups, or to use the drug for patients or not. Now we imagine, what if there was a policy that required there to be, could somehow require there's no bias in the adverse event treatment effects, so we shut down that, we make that dimension representative? What would happen, and could that worsen the overall expected value of net benefits that gets estimated in trials? Well, it's going to depend how sponsors respond to that. So we assume that sponsors are going to adjust enrollment shares as little as possible, like minimizing the Euclidean distance between current shares and the next shares in order to achieve this regulatory target of no expected bias in the serious adverse event harms. And we derive a condition under which doing that sort of correction will lead to at least as good, or if not better, external validity of the net benefit estimate from the trial. And basically it comes down to correcting serious adverse event representation will improve net benefit validity unless the highest harm patients have much larger medical benefits than anybody else, and then you could get this sort of overshooting where enrolling more of those patients with high harms because they have such high medical benefits actually worsens the representativeness of the trial. We do a calibration exercise to try to get a sense of whether that condition is likely to hold in the setting of oncology drugs, where we're focused on. We think it likely does hold, that the utility costs of a serious adverse event are about 4 times higher than the threshold that would be needed for this condition to hold. But there's more detail on that in the paper. So then we think about, is there a possible regulatory framework? I'm not going to make a policy recommendation, but I think one reason we haven't seen a lot of regulation here is it's not clear what the right target is. There's so many different kind of comorbidities, and how do you kind of formulate a policy around that? And so what we're suggesting here is that if you have a model that predicts heterogeneity and harms, then you show that model works across multiple cancer drugs, and we have some more validation in the paper showing this isn't just about one drug, this kind of works across different drugs and across different cancers, then you could use that model as a target for regulation. What would that look like? You need to, trial sponsors need to identify who's the target population for the indication I want, use pre-treatment characteristics to estimate the predicted gap in expected serious adverse events between the target population and the trial population. They would need to then reduce or justify residual bias in that based on potential constraints like feasibility, power, ethical constraints, recruitment costs, And then you could imagine a step of post-marketing surveillance to check whether the realized trial population matches the disclosed target population, and if not, at least identify opportunities where you might want, more evidence if there's been substantial drift between who's in the trial and who ends up getting the drug. In the paper, we compare kind of a policy that leads to changing the enrollment of trials to a policy that just reweights existing trial evidence. And there's substantial power kind of loss if you just reweight the trial evidence because of the really selective enrollment and kind of limited overlapping support in current trials. We do 2 back-of-the-envelope welfare calculations in the paper to just consider like how consequential would it be to correct this margin. And we consider 2 different ways in which correcting this bias could change decision-making. The first is it could change a patient and doctor's choice to use the drug for a particular patient. And so we say, okay, what about for the first few years after the drug is released? People are misinformed, and we kind of assume that eventually they become correctly informed about serious adverse events. Would correcting the adverse event treatment effect estimate lead to changes in treatment decisions? And we try to estimate how many cancer patients are on that margin between treatment and no treatment, and where correcting their information about adverse event harms might change their decision. And we estimate roughly $340 million in welfare, kind of potential welfare improvement per year of correcting misinformation about those serious adverse event treatment effects. We then consider FDA decisions and make kind of a back-of-the-envelope calculation of like how many drugs are likely on the margin between approval and not approval based on some kind of moderate change in the serious adverse event profile of the drug. And we estimate much smaller welfare improvement from that, actually, of only $12 million per year, because there's relatively few drugs that we're estimating that might be right on that margin. So we think this is actually much more consequential for what decisions patients and doctors make than for trying to change kind of how the FDA evaluates whether a drug should be approved or not. These are rough calculations. There's more details on how we arrive at them in the paper. Okay, so to sum up, we find that cancer drug initiation causes large increases in serious adverse event hospitalizations, that these serious adverse event treatment effects vary across patients, and they're predictable based on patients' pretreatment comorbidities, frailty, and demographics. We show that trial participants are systematically lower risk than the target population, and they're less likely to experience these serious adverse event harms. The selection causes trials to understate drug-induced harms for the patients who we think are ultimately likely to want to take up the drug by about 15%. And we argue that a feasible regulatory framework could monitor and help reduce this bias. So thanks, and I'm looking forward to your discussion, John.
John Skinner is going to discuss.
Aging Summer Institute. This is kind of a novel experience. So I want to start with a summary of this terrific paper. I asked Claude to sort of give me the best summary. It spent 20 minutes, and this is what it came up with, which you may notice shows sort of a similarity. So I think it's like it's all in the title, and we can kind of finish up. But I do want to talk a little bit about it. One of the things that they're very careful to sort of mention is that they don't necessarily measure benefits, but they do measure adverse events. I think in some procedures, the two are sort of mushed together, and so I'm going to talk a little bit about a different example. But they have 2 cohorts. One is they estimate that people at higher risk are more likely to experience adverse events, and I think that predictor is actually could be really useful. You can imagine an app where the patient comes in and you sort of put in a few numbers and they say, look, you have an elevated risk of an adverse event. How do you feel about this drug now? So it has sort of real kind of clinical implications. And then they do a trial participation sample, and not surprisingly, they find that the trials have very few people with, far fewer people with these risks, high risk of adverse events. What I found really striking was even if you sort of get the age, sex, race adjustments right, that you're still missing, that there's so much variation within age, within sex, within race in terms of likelihood of adverse events, that you're still not sort of getting the true picture. So I think that's an important point. And then there's this additional bonus, which is, how best to sample patients for RCTs. And, I think it's sensible that in order to get the right average treatment effect, you need to have the population. The challenge is knowing what the population is going to be. So, because in theory, this is going to depend on sort of adverse event. It's asking the drug company to predict what their future patient composition will look like, which could be difficult. But first of all, I think this is like my favorite kind of study because we've got really good clinical expertise. We're sort of, bringing together sort of modeling methods, and but we know that the clinical part is right. So for the economists without sort of clinical training, it's like, no, this is fine. This is really good. But the larger question, I want to sort of step back and ask, well, why do we see so many studies like this? And suppose, we asked, what are current trials maximizing? Well, basically it's saying, is there a group of patients for whom the treatment could benefit? Because that's kind of what they need to get FDA approval. So they're trying to identify the people at greatest who can potentially benefit the most. So that's how they construct their sample. And they also want to maximize their statistical power by avoiding the risk, these risky patients where, bad things can happen, and that completely messes up their statistical precision. And I see Joe Newhouse is here. Doug Steger told me about $1 million babies in the RAND trial, and that's like, that messes up your statistics really badly. Is this fair enough? Okay. So what they're doing is completely rational. The problem is they come out with this study, and practicing physicians say, oh, I just read this randomized trial, and I think this thing is really good. And so that's where you get into problems, is the translation from a very limited sample of patients to, oh, let's use this for everybody. So they make this very compelling case, but I'm going to argue it's even worse than you think. And I'm going to go back in time. This is before my time in health economics. An article from JAMA in 1998. This is sort of the Dartmouth crew, David Wenberg, who's Jack's son, John Birkmeyer, Elliot Fisher, and they looked at these two randomized trials on carotid endarterectomies. And there were two RCTs, and there was very, very low mortality, 30-day mortality rate, 0.1% and 0.6%, and it was so low that basically the FDA said, or the trialists said, we have to stop. It's no longer ethical to put people into the control group anymore, so we have to start doing surgery. The carotid is, right here, it kind of gets gummed up, and people would come in with a Roto-Rooter and kind of clean it out. There's a balloon more recently. So they looked at the Medicare claims data, and you can see there's the 30-day mortality rate. Those are the two trials. As in this paper, the patients were, shall we say, curated, carefully chosen. The trials were conducted mostly in high-quality academic medical centers, and notably, the physicians had to apply to be in the trial. So they had to send in their previous carotid surgical records, and they had to be under some percentage in order to be in the trial. And if they started experiencing post-operative complications, there was a risk they would be dropped. They would look at this. So these are curating physicians as well. And so what they did is they went and they identified the trial hospitals, and then they found, this is sort of the 1.5, a little bit higher than 0.1, those were the mortality rates within those hospitals, so much higher. So this is sort of evidence of this, high physician quality. And then if you looked at sort of the low-volume hospitals, it was even higher. So this enormous gap between the RCTs and the actual care also reflects kind of the skill of the physicians again, it may be alpha, it may be gamma, but it's clear that variation between what you get in the community versus what you get in these trials could be very large. Second thing, so they're concerned with false positives. But this is my sort of pet peeve about randomized trials. There's also this problem with false negatives. And so here's a trial of celecoxib, which is a treatment for cancer, and it was in JAMA, and 5-year survival rate was 84% versus 81.6%. That's actually a 14% decline in mortality. Like, if somebody told me that, it's like, yeah, bring it on, I'll take it. But you can see that the confidence intervals, shall we say, just dripped right into over 1. And so the conclusion was not like, well, gee, we really don't know, but this might be useful. But the conclusion was, this did nothing to improve disease-free survival. And that's what the editors force you to do. Like, you can't just say, well, I don't know. And this is a problem with power. And basically, like these trials, they don't enroll as many people as they can. They, it gets to the end of their funding. They have to sort of publish what they have. And so you can, again, go wrong here because people will say, oh, yeah, I saw a trial about this, and it doesn't really matter. So I think that's another place where trials are a huge problem. So conclusion is, this is a really convincing study that meets the highest standards of interdisciplinary work. The heterogeneity effects are pointed out by patients, that's certainly true, but it's also very, very likely for providers as well. And I think that's something that we could use more research on. This is really good ideas about changing the sampling of RCTs, but I also think there's a huge role for post-surveillance monitoring, which they mentioned. I think the gold standard here was for implantable defibrillators back in, I think, when Mark McClellan was running the FDA. He said, oh, you have to have registries. So there's incredibly detailed data on each patient who got an ICD, and you could really do the right follow-up, look at heterogeneous treatment effects across providers, across patients. That was discontinued because it was onerous with regard to collecting data. But you could imagine if you make the electronic health records available to like these large language models or things like that, that you could make those kinds of sort of AI-related registries much more accessible and available for researchers to kind of check to look for these heterogeneous treatment effects. That's it. Thanks.
Thanks, John, for that excellent discussion. I think I agree with pretty much everything you said, so I'm not going to try to rebut it. I think there's a lot of work to be done in understanding like different sources of heterogeneity and treatment effects. I think surgical trials are probably an even worse sandbox that we didn't look in for this study, but it's the concerns that you raised there are probably also somewhat applicable in the drug context as well. So anyway, I'd like to open it up for questions.
Okay, it's on. Yeah, so I have a question and maybe a quick comment. The question is, can you tell how much of this is people being screened out because of explicit rules in the criteria, or is this some kind of unobserved to us thing that's happening on the side of the screening staff?
That's a really good question that I don't have a satisfying answer to, but I can talk a little bit about because we spent a lot of time thinking about it. So there are systematic exclusion criteria for all of these trials. The exclusion criteria are often based on things like a lab value, so not do you have kidney disease, but do you have this threshold. And so they're not readily mapped to like in the SEER Medicare data that we have. In fact, it's very hard to think of a data set that would give you kind of that level of granularity at the scale that you would want it to be able to match like something close to here's the national population of people and here's how they get filtered on exclusion criteria. We had a nice proposal to try to do it at MGB that we couldn't find funding for, but maybe one day. I think more broadly though, the way we think about these exclusion criteria is that they're an endogenous choice of the trial sponsor to try, and I think in some cases, at least partially motivated by like a kind of desire to avoid evidence of adverse events within the trial. And there's been some attention in clinical kind of policy circles recently about thinking carefully about these exclusion criteria, which ones are really necessary, and could we relax some to get patient populations that are more reflective, that allow older patients into trials. And so there's some kind of explicit discussion of the sort of endogenous role that these play in trials and thinking about ways to loosen them. Sachin, do you have anything to add to that from here?
I'm not sure if this is on.
Sorry to put you on the spot.
No. I think that exclusion criteria are clearly an issue. In oncology trials, there's a move through the professional organization ASCO to remove some of them, and in efforts of improving representation, but representation more broadly, not specifically with regards to the clinically relevant dimensions of heterogeneity of harm, which we focused on here.
Great, and then just a quick comment, which is Darius Lakdwala has this work on like the value of hope, and I mean that might be higher for people that are kind of high risk or ill, more ill, and so just thinking about that in terms of how people value risky, a chance when you think about the benefits might be.
Yeah. And I think one thing that's kind of interesting about this context, unlike maybe some other places where I study, is that there's kind of a weaker relationship, arguably, than like between the severity of someone's cancer and their vulnerability to serious adverse event. I mean, there's some correlation there, but they're not so tightly connected as in like, I do work on blood thinners where like it turns out that risk of bleeding, side effects, and stroke are really closely related. And so there's this really kind of baked in trade-off between benefits and harms, and here the relationship's a little bit weaker. Yeah.
I just was wondering, is there evidence that, or, just lore that physicians post-approval sort of are like, some of these things are like, the patient population is younger, obviously you're like, oh wait, I'm willing to trade off some of these costs and benefits, but, in terms of the comorbidities, is there evidence that just, physicians are sort of conservative and saying, wow, you've got a raft of comorbidities, I don't have the study that, I don't have that regression line that you want me to have, but like intuitively, I'm just going to be a little cautious here.
Yeah, I think that there's evidence from the clinical literature to support that type of reasoning, that like that patients who are multimorbid and frail are less likely to initiate treatment with cancer drugs because of concerns about toxicity and side effects. So I think that's exactly right. And the secondary point here is like, that I think physicians have a gestalt about who's enrolled in trials, but trials are not very transparent about this. So they do report their average age, but these sorts of comorbidities that we're using to predict serious adverse events in our data are not reported in the clinical trial publications themselves. And when we tried to chase down the microdata, they seem to not be systematically collected. So it's hard to even kind of quantify how close a given patient is to the trial evidence that you're looking at. So they're kind of left, as you described, with their sort of impressions.
Seems like a practical implication of this is that in trials, if people had the serious adverse event index, that's the dimension on which you'd look for heterogeneity in treatment effects, since that's the key issue, and that might be that's doable at least going forward.
Right, so we're proposing that this is there's a technology solution to the extent that you can predict these things, as long as you can show that this model kind of holds up maybe within a class of drugs or, but a little more broadly, yeah.
Do you want to, okay, I'm next. Can I, okay, so I'll go next. This is super interesting, and I love John's discussion. To get something, can you talk a little bit about the financial incentives of these trials versus health insurances? Because I think a little bit about this in the context of pharmacogenomics, where people are doing all these things ex post, when in reality they should be doing this heterogeneity, they stratify these trials ex ante, right? If we really want to get to but they don't have an incentive, right? Because they want to try to apply this to as many people as possible. So, yeah.
Yeah, I think there's a big gap because even when the trial population is somewhat specialized, the labels that we see on FDA approvals are quite general, so they don't reflect all those exclusion criteria that might have been applied in the trial. So it becomes this kind of shrouded attribute, I think, of the evidence. So, yeah, I agree. Yeah, Marcella?
Okay, and then I'll hand it over to David. Fantastic work. Oh, I'm sorry, Amanda, and then, okay. My question was about the dynamics. So twofold. Initially, I would imagine that drugs are more toxic when they're first introduced, and then they kind of improve their side effect profile over time. So is that something you can look at? And is there still something to be gained from a sort of knowledge externality just by knowing the mechanism of action and that it is effective? But there are these adverse events that we want to try and minimize through further innovation. And then the second thing I thought about was just that a lot of times, people who have frailty or comorbidities are on other drugs. So how much of the SAEs are coming from drug interactions with that drug? And could those be mitigated over time as there's innovation in other parts of the market? Thanks.
That's really interesting. I don't think we have results to speak to that, but I think it's an interesting area for further exploration. Thanks, Marcella. Yeah.
I wanted to bring up that there is an interesting and related paper on the Frontiers in Econometrics program that's coming up on Thursday. It's called Site Selection for External Validity, and it's by Michael Gechter and Kay Hirano and co-authors. And they're looking at a development economics context, literally which geographic site to select for external validity. But there's clearly a parallel in clinical trials to think about which demographic groups to pick. And they use statistical decision theory to think about which ones to pick for external validity. And there's an element of representativeness there, where you want to use the microdata and find the group that's more representative. But then there's also an element that they come up with, which is that you should experiment the most where uncertainty is the greatest. And I wonder how that maps to this context. Is there greater uncertainty in these demographic groups that have more risk of severe adverse events, or where is the uncertainty the greatest? Because that's the extra dimension that the econometrics literature is bringing in.
Yeah, I think that's a really good point. So in this case, we're just sort of saying we're going to take the average treatment effect from the trial and assume that people are trying to use that to inform the average treatment effect in the population. If you have a more sophisticated model of extrapolation, or you're thinking about bias variance kind of trade-offs, then you might get to a different answer about optimal trial design. And that's a question that Jason and I have been actively working on, so stay tuned, and hopefully we'll have more to say that connects more directly to that literature. Thanks for pointing us to that other work. Yeah.
So I want to pick up on one theme I think that came up with Doug's comment, which is it seems like the implication of this depends on whether you think there is a single dimension of heterogeneity which you can actually identify, which is the risk, in which case you could then condition your clinical trial strategy on, maybe I should do it in the low risk people first and then do a separate trial in the high risk or whatever. Or if you think, no, this is actually just indicative that there's a lot of heterogeneity along dimensions that may vary from treatment to treatment, in which case I can't design an ex-ante trial because I have no idea actually what that basis of variation is going to be, and so only ex post can I do this and see what it means. The first is clearly easier because you can design with that in mind. And then the second is going to be a lot harder because then ex post, someone has to always say, what does that look like in this particular case? So I guess I'm sort of curious about how you want me to think about this. Like, is this the dimension, or is this just one of n dimensions?
So I think likely this is an incomplete description, like the particular risk model we develop of the potential heterogeneity and adverse events for cancer drugs. But what we show, and we show in the paper some like kind of exercises to show that it kind of holds like across, like you can develop the estimate in other cancers or in other drugs, and it's still predictive kind of across different samples. So we think when we have we wouldn't presume that this applies like outside of oncology, like you would want kind of separate validation of a model for the context that you're working in. But when we have such a model, it seems to be a potentially useful target for looking directly at the question. And there might be cases where it's not appropriate, as you point out. I think they're the kind of minimum bar here that we still haven't quite cleared in clinical trials, is just maybe more transparent reporting of those common comorbidities and other dimensions of patients, so that at least you have open the door to that future work on heterogeneity in cases where we don't have a good model to inform ex ante.
A question about whether, if there's a way to look at the different incentives at the time of getting the physicians to be part of the trials versus in the later sales part, by looking at the characteristics of who the physicians who are targeted for marketing is compared to the ones in the trials. If you see systematically different characteristics, I wonder if that helps.
Yeah, that's really interesting. I hadn't thought about that dimension, but that could be a neat future angle. Thank you, Kosli. Yeah, Cody.
Part of this is because the SEER data makes this kind of study possible, but I wonder if you've thought much about how the sort of result that there's sort of healthy selection into trials is a general phenomenon versus, it's a thing in cancer trials in particular. If you think of some other drugs, like most prominently right now, like the sort of like GLP-1 drugs, if you look at the population of people using the drugs versus the people that are in the clinical trial, it's the opposite result, that the sort of post-trial market has much healthier, younger people taking the drugs than are in the trials. And I wonder what the pattern would be for a whole bunch of different classes of drugs, basically.
That's interesting. I don't know that I have a global answer, although Dave Chan, Jason, and I in a different configuration have work on anticoagulants showing that in that case, the trials also selected kind of patients who, even though they were like at high risk of stroke, seemed to have lower than population risk of like bleeding adverse events. So that's like a kind of a cardiovascular context where we see kind of a similar pattern of selection into trials. But as you point out, the GLPs kind of move in the opposite direction. I think it's kind of maybe a unique case, but I'd have to think more broadly before I promise you that, where like the drug is so attractive even to relatively healthy people for reasons that might go beyond health, direct health effects.
I think I'd agree. Maybe mental health drugs in general might be a category where it could go the other way. I don't know.
Alzheimer's is just like people are positively
selected. Okay, interesting.
Thanks.
Great. I think we are at time. Thanks for a fantastic presentation and discussion. And we're going to we'll be back at 11. Elaine Shen is going to present.
Great. Thank you so much to the organizers for putting this paper on the program. I'm really excited to present what is hopefully going to be my job market paper, conditional on what the discussant has to say about it in a few minutes. But this is joint work with my wonderful co-author, Margaret Kalis, and she's also going to be on the market this fall. So markets often rely on intermediaries to translate complex products into consumer choice. And this is especially common in credence good markets. So what I mean by credence good is these goods where it's hard to tell quality before and even after you have some experience with the product. So we talked a bit about like financial advice, that falls into this category. My favorite example is dentists, because if a dentist tells you you need to get a pre-cavity refilled, you don't really know what that means. You're not sure if you really need it. Even after you get the treatment done, you're not sure if the dentist was just upselling you. So that's what I mean here. And these markets are often really big and important and heavily regulated, but we still see headlines like this: US accuses health insurers, brokers of Medicare Advantage kickback scheme. And that's what we want to study. We want to study these principal agent problems in this big, important market, the market for Medicare advice. So some background on the Medicare market that I'm sure a lot of people in this room know already, but Medicare is a large government-backed health insurance program that insures almost 70 million seniors and individuals with disabilities. So you might think, okay, everyone makes this, or almost everyone makes this decision. How hard can it be? And then even if I make a mistake, I still have health insurance. How bad is it? But in reality, nearly 1 in 4 seniors report having medical debt, and roughly 1 in 3 seniors avoided medical care due to the cost. So what Medicare plan you choose does have important implications for your health, but also for your financial well-being. On top of that, it's a very complex decision. There's multiple different types of Medicare plans. They have different trade-offs, and it's hard to reverse. So depending on which exact plan you have, you might not be able to switch plans without medical underwriting. So given that it's such a consequential decision, a lot of seniors choose to outsource this decision to expert intermediaries or Medicare insurance brokers. So this could be good because brokers presumably have more experience with Medicare and more expertise than seniors who are making this choice for the first time and sometimes only time in their lives. But on the other hand, these brokers are salespeople at the end of the day. They might work with some and not all insurance companies. They're paid different amounts for different Medicare plans. So you could see why this would be a situation where there might be some conflicts of interest. And then finally, going back to this credence attribute that I mentioned earlier, it could be hard for seniors to evaluate plan quality and the recommendation quality, and that would prevent them from being able to punish brokers for low quality advice, and that could allow this low quality advice to persist in equilibrium. So in this paper, we're going to ask, are brokers giving advice that maximizes consumer welfare? Are they giving good advice? And if not, why? And thinking about some of the limitations with studying this in observational data and why this hasn't been answered before, to answer this question, you would need detailed data on consumer preferences, so things like provider network preferences, prior authorization, and detailed plan information. And this isn't something that you can just ask seniors, because a lot of them don't even know which exact Medicare plan they have. So when we first started working on this project, I asked all my family members, and I can tell you 0% of them know what Medicare plan they have. On top of that, you would need a setting where you can clearly tell a mistake or a bad choice. And then finally, because we're interested in these principal agent or agency problems, you would need detailed data on broker use and broker recommendations, and that's not really tracked. So how do we overcome these data limitations? So we're going to conduct an audit study where we hire senior citizens who are secret shoppers, and we have them call Medicare brokers. And that's going to allow us to design a standard profile or assign consumer preferences in a way that lets us create a benchmark for fit or for what the best plan recommendation is. Because we're interested in these agency problems, we're going to focus on scenarios where the broker preferences or the broker incentives and the consumer preferences are in conflict, where there's a conflict of interest. And then finally, we're going to hire train these seniors, randomly assign them to call a somewhat representative group of brokers, so brokers from large call centers, online databases. On top of that, we are interested in why brokers are giving low-quality advice. So we're going to use 2 experiments within the audit study to look at how advice responds to incentives, how advice changes if incentives change. And then finally, not going to talk about this at all today for time, but in the paper we have a structural model, and that lets us simulate counterfactuals and quantify welfare. Okay. So again, might be a little bit too much information for this audience, but just so we're all on the same page, this is the decision tree that seniors face when they retire. So can't use this. So the first decision they make is they choose between Medicare Advantage and traditional Medicare. And then conditional on having traditional Medicare, you might get a Medigap plan or a Part D plan for drugs. And about half the population, roughly, has Medicare Advantage or MA, and about half has traditional Medicare, also called Original Medicare, Fee-for-Service Medicare. And about 14 million people have Medigap. So there's trade-offs, thinking about the first part of the decision tree between Medicare Advantage, MA, and traditional Medicare. Neither plan is strictly dominated, so there's pros and cons of each. And think of these trade-offs as trading off between an upfront monthly premium and coverage. So Medicare Advantage has a lower monthly premium, but you also have less coverage. So you need things like prior authorization, there's network restrictions, there's potential claims denials, et cetera, versus traditional Medicare and Medigap has more comprehensive coverage. You could see pretty much any doctor, and you don't have to deal with like network restrictions, prior authorization. And then Medigap plans fill these gaps in the traditional Medicare coverage, so things like coinsurance, copay, deductibles. And the key feature I want you to keep in mind about these Medigap plans is that they are homogeneous goods. So due to regulation, they're standardized. So think of these like the S&P 500 index funds of the Medicare market. They even more extreme than index funds because all the claims are approved and denied by CMS. So it's very standardized. The claims approval is basically automatic. There's really no differences except for price. And there's a line on Medicare.gov that literally says there is no difference except for price. There are, however, pretty big differences in how the brokers are paid for each plan. So brokers are paid roughly $750 per Medicare Advantage or MA enrollment, and they're only paid about $350 per Medigap enrollment. And importantly, brokers are paid a percent-based commission for Medigap. So the higher premium you pay, the more they're paid, and that's usually about 10 to 30% of the premium. Okay, so this is going to translate into the 2 decisions that we're going to look at in the audit study. So the first one between Medicare Advantage and traditional Medicare. Second decision, regardless of what happens in the first decision, we're going to have the senior redirect the conversation and ask for a Medigap recommendation. And because we're interested, again, in these conflict of interest scenarios, we're going to design a profile and design preferences where the senior is not a good fit for MA. There's more detail. I can give you more detail on this. Basically what we do is we go to Medicare.gov. They have descriptions of these different plans, and we take all the reasons Medicare.gov says you should not have MA, and we give all these reasons to the senior. So these are things like, I don't want to deal with network restrictions. I want to be able to see any doctor no matter where I go. And then the second decision is a lot more straightforward because Medigap is a homogeneous good. So the broker should just be recommending the lowest premium plan. Okay, so this is what, so just to recap quickly the audit study design, we're going to send 109 seniors to make 637 phone calls to Medicare insurance brokers, and we're going to focus on scenarios where broker commissions and consumer preferences conflict. So for decision 1, the broker should not recommend Medicare Advantage, but they're paid $750 versus $350 when they do recommend Medicare Advantage. So outcome 1 is going to be the share of calls where brokers recommend Medicare Advantage or MA. And then decision 2, again, brokers should recommend the low premium Medigap plan, but they're paid a percent-based commission, percent of the premium you pay. So, oops, sorry. Okay, so the second outcome is going to be the Medigap markup, or the premium of the broker recommended plan minus the low-cost identical plan available to the consumer. Okay, so that's what brokers should be doing. What are they actually doing? So unfortunately, brokers are providing misaligned recommendations on over half of calls. So for outcome one, remember about 0% of brokers should be recommending MA given the preferences that we assign to the consumer. But about 32% of calls brokers are recommending MA, and this is going to translate to about $5,000 per year of welfare loss for the seniors, or about $76,000 in lifetime present value mortality adjusted loss, $76,000 lifetime loss. And then for the second outcome, the Medigap outcome, so remember these are standardized plans and homogeneous, so they should recommend the low-cost one. The markup is going to be about 29%, or about $400 a year for the broker-recommended plans, and this is going to translate to roughly $12,000 in lifetime monetary loss. And especially for the second outcome, this is just a direct transfer from seniors to insurance companies, to insurance brokers. They're getting identical coverage, they're just paying more for it. So we're going to say brokers provide misaligned recommendations if either one, they recommend Medicare Advantage, or two, they recommend a high markup Medigap plan. And we're just going to use $360 a year, $30 a month. That seemed reasonable, and it's close to the mean. And combining outcome one and outcome two, about 52% of brokers are providing misaligned recommendations. Okay. So the next question we have is, does advice change when incentives change? So we want to understand why brokers are providing these recommendations. So we look at this two different ways. The first experiment, or the first way, is using a large, or a natural experiment, where large insurance companies stop paying Medicare Advantage commissions. So this happens sometimes when companies misprice their plans, and because of regulation, they can't just immediately pull out of the market. So what they do to slow enrollment is they'll stop paying broker commissions. And that's what happened for a subset of brokers in our setting. So before September 1st, they were paid about $750 per MA enrollment, and then after, they were not paid, or paid $0 per MA enrollment. And what we're going to do is we're going to collect audit study data before and after the change to look at how things changed. Okay, so maybe unsurprisingly, recommendations change when the incentives change. So changing the commissions does lower the Medicare Advantage MA recommendation rate by 21 percentage points. But importantly, it does not go to zero. So two takeaways. One, obviously, at least part of these recommendations seem to be driven by incentives. But two, there also do seem to be some sort of friction, whether it's training on the broker side or product specialization, but some sort of information friction that is causing brokers to still recommend Medicare Advantage, one, when it's not a good fit for the senior, and two, when they're not being paid commissions for it. Okay. So the next experiment, we're going to look at if advice changes when perceived competition changes. So this is partly motivated by this fact that 66% of seniors only talk to one broker before they enroll in a Medicare plan. So this is despite the fact that this is a very, in theory, competitive market. It's very easy to just dial the 1-800 number, make another phone call, talk to another broker, but most seniors aren't doing this. So the treatment is we're going to tell the seniors at the very beginning of the call, so it's most salient, we're going to tell them to emphasize that they plan to talk to multiple brokers. And the idea is we're trying to increase perceived competition, so they could say things like, I want to get a few quotes from different brokers before I make a decision, I want to shop around, I want to get a few recommendations. But importantly, there's no other changes to the script and no other changes to the senior preferences. Okay, so what is this treatment doing? So this table is just showing the treatment against the two outcomes, or two main outcomes of interest, the MA recommendation and the Medigap markup. And as you can see in column one, the treatment assignment is causing the rate of MA recommendations to increase. So remember, that means that brokers are being paid more. If the senior enrolls in MA, they'd be paid $750 versus about $350. And this is bad for seniors. So the net welfare loss for MA enrollment was about $5,000. But then if you look at the Medigap outcome, it looks like there might be a little bit of a different story. So the Medigap markup is actually going down by about $85, $86. Remember, this means that seniors are just paying less for identical coverage. This also means brokers are being paid less because brokers are paid a percent-based commission. And again, this is good for seniors, paying less for an identical product for identical coverage. So what is going on here? Why does it look like these two results seem to be moving in opposite directions? So it turns out in both cases, this competition treatment or perceived competition is causing brokers to compete on price. So remember the MA recommendation or the MA plan, it's less in upfront premium, but it's also less coverage. You have network restrictions. You have all these things that seniors say they don't want, but it is lower cost. And then for the Medigap markup, you're just paying less for identical coverage. So our takeaway from this is this perceived competition or this threat of competition could have some unintended consequences, especially in these markets where maybe consumers don't fully understand the product and don't fully understand quality, by causing brokers to compete on price at the expense of quality. Okay, so finally, we want to ask, why does low quality advice persist? So one thing you might think could help discipline the market is feedback. So maybe consumers work with a broker, they get a bad recommendation, and they give them a bad rating. So that's what we test. So after every phone call, we have our secret shoppers provide a rating for whether or not they would recommend the broker. And this graph is just showing our two outcome measures, RECOM and Medigap markup, against this probability of getting a high rating. So basically we're asking, does objective quality measure correlate with this broker rating that the seniors or the shoppers are giving? And the answer is no, so it's probably hard to see, but both of these are overlapping with 0. So it doesn't look like consumers are able to recognize high quality advice. And then the second thing you might think is, okay, maybe seniors don't recognize good quality advice immediately, but maybe they're learning over time as they gain more experience. So that's the second thing we're going to look at. So this is doing the same correlation, but just split by call experience or call bucket. So on the x-axis, moving from left to right, is increased experience, more calls, more experience. And the green shaded area would imply learning. So more negative line would mean the senior's better at telling whether advice is good or the ratings are more correlated with advice quality. So basically it does not look like seniors are learning over time, maybe a little bit over for the MA outcome on the left, not really for the Medigap outcome on the right. Potentially around the 20th call they're learning, but that's not really something seniors are doing. Most aren't even making more than one phone call. So we think of this as directly testing this credence attribute that I mentioned earlier, testing whether consumers are able to tell quality. And the results suggest to us that they aren't able to tell quality, and this could be allowing low quality advice to persist. Okay, how much time do I have left? Okay, I'm going to skip this, but these are some other things in the paper that I won't have time to get to. So we have some suggestive evidence of broker information frictions. We have a structural model that lets us look at counterfactuals, and we do some LLM analysis on the phone call recordings that we have. Okay, so in conclusion, this paper is asking, are experts giving good or high quality advice? And unfortunately, the answer is not really. So brokers are providing misaligned recommendations on roughly 52% of calls, and that's leading to over $12,000 in lost lifetime retirement wealth for seniors. And again, this $12,000, this is just the Medigap number. It's actually a lot larger for the MA number. And then we also ask why not, and we use our experiments to try to look at mechanisms, but it looks like it's a combination of the broker incentives, but also that information frictions on part of the consumer, and this inability to tell quality and punish brokers might be contributing as well. And then finally, thinking about the broader implications, an important takeaway that we had from this was that incentive-based levers alone might not fully discipline advice, especially in these complex markets or these credence good markets where consumers aren't able to tell quality. And then in follow-up work, so I think this work led to a lot of other interesting questions for us. So one thing we really want to think about is this matching of consumers to brokers and selection into broker use. And that could potentially have welfare implications. And we've started doing a little bit on this, and happy to talk more about this. The other thing is advertising related to this matching point. So we have some cool advertising data that we want to do some stuff with. And then finally, AI advice, just jumping on the bandwagon. But given that this low quality advice is driven by a combination of incentives and information frictions, especially the information frictions part, we think that AI or technology could help alleviate that as well. So that's all I have. I'm very excited to take questions and excited to hear the discussion.
Jason Affleck is going to discuss the paper.
All right. So, whoops. Okay. Oh, well, I see it. All right, so thank you, Elaine. Thank you for inviting me to discuss what was, I think, a very interesting paper for me to see that I think fills a real hole in the literature. The basic question is, look, a lot of people go to these brokers for help choosing health insurance plans. Are the brokers giving good advice? The paper then asks further, is it the case that the commissions, the way we're paying these brokers, impacts whether they're giving good advice via natural experiment and then via a randomized experiment? How does competition impact the quality of the broker advice? And I think the real hole it's filling in the literature is that what we've been able to do in the past is to either A, look at really limited and circumscribed choice environments where we knew that the plans only varied along one dimension or a handful of dimensions to see if choices were good, or B, we looked at environments like, Medicare Advantage plans in Gruber, Handel, Kina, and Kolstad that I'll talk about later, where on the one hand, you can see big differences in the cost of different Medicare Advantage plans, but on the other hand, you worry that, maybe there's these other kinds of unobservable differences across plans that you have to account for. And what this study does using this secret shopper method is basically say, okay, we can kind of control for these unobservable differences and then see how do brokers behave and how might it impact plan choice. So the way that the paper defines a good choice is they basically define these secret shoppers that are designated to favor traditional Medicare. So the things the secret shoppers say are all the things that would make traditional Medicare look good relative to Medicare Advantage, that they're going to move a lot, they don't want narrow networks. And a thing they do in the paper is they sort of validate that, okay, there are other differences between Medicare Advantage and traditional Medicare, like Medicare Advantage plans might have lower premiums. But if you use this broker-stated willingness to pay, it seems like the differences in these characteristics ought to swamp those premium differences. And to a considerable degree, it should be worth almost $500 a month for these people to choose traditional Medicare over Medicare Advantage, given the average value of those characteristics. Then within Medigap, I think the case is arguably even stronger. It's basically you have what are essentially standardized plans, some of which have lower premiums and save people money. I think that this Medigap argument is very defensible. I think there's a few possible remaining differences between the Medigap plans, even given what the secret shoppers say. It's things like, some plans might raise premiums more in the future, even though they have similar premiums today. I don't think that's on the radar screen of any of the brokers or the consumers. And the bottom line is the brokers recommend a 29% or $400 markups over the best available Medigap plans that have essentially identical coverage. So this seems to me a real deficiency on the part of the brokers. For Medicare Advantage, I'm not quite so convinced about the welfare criterion. Based on my own work with Mauricio Caceres, Peter Hull, and Amanda Stark, I kind of think that Medicare Advantage plans, the first order differentiation is actually that because of the networks, some of the plans do a better job of making patients healthier than others, and that really has first order consequences that swamp everything else. However, I don't think the brokers know anything about that. So I think the paper does a perfectly good job of measuring the broker preferences and whether the brokers are telling people to choose the plans that the brokers think are best given the information available to them. And so I think it's pretty persuasive that the brokers are often recommending Medicare Advantage plans, even though they think if they were doing this for themselves that they would not choose those plans given the features the secret shopper describes. So what's the evidence for this? So they have this natural experiment about what happens when you change the commissions for the brokers, and I would call this like a tier 2 event study. What I mean by that is a tier 1 event study, you look at it and you're like, okay, this is 100% clear cut what happened. Here you look at the event study and you're like, okay, well maybe there's a little bit of a pre-trend, I'm not completely sure, but certainly in a Bayesian sense, this event study makes me update that it's like, okay, it seems more likely that once they eliminated the MA commissions, the brokers were less likely to recommend Medicare Advantage plans. And then they had this very nice experiment where they randomized whether the shoppers, say that they're going to shop around and go to other brokers, and this makes the brokers more sensitive to this makes the brokers say, okay, we can't recommend these expensive Medicare Advantage plans as much, Medigap plans just to get the premium, and then also shift towards recommending more of the Medicare Advantage plans because they make less from the Medigap plans. So clear evidence brokers respond to incentives. They also have this kind of interesting thing, clear evidence that the brokers just don't know stuff. Like they ask them questions about how the Medicare Advantage plans work that the brokers really should know, and frequently the brokers just don't know basic facts about like how copays and switching and stuff works in Medicare Advantage plans. So what should we do about this? Well, the paper simulates some different counterfactuals about what if we paid the brokers differently? What if we trained the brokers to correct their misinformation? And it's like, yeah, okay, in their calibrated structural model, these things seem to really have benefits. I think the simplest solution is that we should mandate that brokers ask Frontier AI and share that report with the consumers. I think that the fundamental problem here is, of course, consumers could ask, Fable themselves if they had a subscription. The problem is they don't know that the models are actually trustworthy about this. But if you go to a Fable or stronger model and you say, hey, imagine a patient with these characteristics, what should they choose? It'll be like, are you punking me? Like, is this some kind of joke? Of course they should choose traditional Medicare because you've just described all of the things that could possibly make a person want to choose traditional Medicare. So I think basically we should just force the brokers to say, hey, I'm recommending this, but also here's the report that a Fable or stronger model gave, and you can cross-reference my recommendation against that report. There's a more general issue, as I mentioned, for Medicare Advantage that the Frontier model still can't solve, which is the information about which plans will make you healthy, where the fundamental issue is we could tell people which plans have good outcomes, conditional on observables, but then you worry that giving people that information will create incentives to game by the plans only enrolling healthier people, so they look good on these metrics. My view is actually that we should do this anyway, because they already have an incentive to game the risk adjustment system, and it would basically be the same incentive, and they're probably gaming about as hard as they can. But I think this is a big unknown, and it would be good to have better empirical evidence on that question. In just the last minute or two, I want to say something completely different, which is I'm a little bit worried that this whole conference is a little bit like an Aztec conference in 1519 on the dangers of counterfeit currency, or an Edo Symposium in 1853 on whether merchant wealth is upending the Confucian social order. In both of these examples, what happened is the entire social order just no longer existed in 10 years. I'm worried that economists have not fully internalized this possibility that the best forecasters are predicting generally capable AI systems that can do everything humans can do by 2032. And so I don't want to encourage sort of groupthink where people at this conference see other smart people doing business as usual, and that prevents you from being like, maybe I should be doing entirely different or more creative things that are different from what I normally do. Of course, there's strong arguments for the status quo. There's high uncertainty about what will happen. Nobody knows. There's your comparative advantage. You do what you are trained to do. Those arguments are defensible, but they may be becoming less so, so pay attention. If what happens in the next 6 months or the next couple of years is you're like, oh, the new Anthropic model is only a little bit better, it still doesn't have good judgment, and then you're like, oh, wait a minute, now it does have good judgment, but it still doesn't have my taste, and then you're like, wait a minute, but it does have my taste, that's a signal that maybe you should be a little bit less inertial in the things that you're doing, and maybe as a profession, we're just going to need to do completely different things. All right, thank you.
On that note, we're going to have Elaine do the traditional thing of taking, react quickly
Yeah,
if you would
one-
like, and then please let me know if you have if you're lining up for questions.
Thank you. I'll go back to. Okay, so thank you so much for that discussion. That was, especially the last point, was a lot to think about. So I don't have a response to that just yet. But I think, so on some of the things that you mentioned, I think all really good points and agree with them. Some institutional details that I skipped for time. So your point about raising premiums in the future and how that's probably not something brokers are taking into account. Yes, absolutely agree. The other thing we did is we focused on state that you can change plans every year, so a state with a birthday rule. So we did that because, even if the plan increases a lot, the broker should just be then switching you into the low-cost plan. And then the second point is the way that these insurance companies increase premiums, it has to get approved. So usually it's a percent-based increase. So it would be based off of the previous premium. So that's another reason why starting with a low premium is important, because they'll probably increase proportionally at similar rates. And then just a note on the MA point, yes, completely agree. One way that we get around this, again, power of doing an audit study and having complete control, is we focus on a rural area. So we focus on an area specifically with very limited networks as a starting point. And then on the AI point, I think that's definitely interesting, and that's something we want to think about more. I think we had like designed, we have actually approval from IRB, and we did a pilot of this consumer choice experiment, and we were originally thinking about making it part of this paper. And one of the things we were thinking was testing this AI advice and testing if seniors were willing to use the AI advice. I think one thing that we're not including it in this paper because the paper is already too long, but we are kind of worried that there might be some AI hesitancy or distrust, especially among older populations. So I think that's something we think is really interesting, but yeah, want to think more about that. So I think great suggestions, and thank you for the discussion. And happy to take questions. Mm-hmm.
Quick question. Was there a tendency for the brokers to recommend Medigap plans by certain insurance companies? For example, AARP, or the reason why I think this is important is because even though they are sort of so-called identical, that United Health is notorious for having a much higher sort of denial rate than, say, Anthem. And so the brokers may be giving them real information to say, look, you may want to pay a little more for this plan.
Yeah, I think that's a good point. I think maybe a little bit less relevant in our setting because the claims are approved by CMS. So the seniors really never interact with the insurance company. So there aren't really differences in the claims denial and approval.
So I have a question and a comment. The question really is prompted by your comment just now that you ran this in rural areas. And I think in most rural areas, just about all the physicians are included because there's not very many of them. And the exclusions are really in metropolitan areas. So I'm wondering if you would get, it's too late now, but if we get different results in a metropolitan area. And I guess that's really a comment too. The second comment which occurred to me while you were doing this is it seems to me a policy conclusion that you could draw from this is CMS could replicate your study and in effect say you're only an approved broker for Medicare if you pass some threshold. particularly for the for the Medigap recommendations, which are clear. I mean, they would certainly get pushback from the insurers, but if you're improving consumer welfare, you could do that.
Yeah, good comments, very helpful. On the first point, we do, so it's a slightly more rural area, like it's not done it's not done in LA, but it's not a completely rural area. But the main thing that, for the network restrictions aspect, we say that they travel and they have providers in both locations. So that would still prevent, or that still has the issue of the network restrictions. And then on the second point, I do think that could be really interesting. In talking to people, our understanding is CMS does do some audit calls like this, but it seems like they don't publish them, or there doesn't seem to be data on that. So yeah, I think that would be great and is a really good idea.
I have a question about the competition result, and it's more like, I'm not sure I should interpret those questions as informing the broker about competition as opposed to informing them about my price sensitivity.
Yeah, I think that great point, and I think, like, obviously we can't get inside the head of the brokers and we don't know exactly what they're thinking. I think they could absolutely be interpreting this as price sensitivity. Another thing that could be going on is there's a lot of research that shows that consumers have like overweight upfront premium at the expense of later costs. So that could be another thing, is they could be reading this as more premium bias and catering to that bias. I think that's fair. I think for us, the main takeaway is just there could be these unintended consequences of saying something like this, like saying you're going to talk to multiple people is a somewhat common recommendation. You would think that that should help align incentives. It doesn't seem to. And I think obviously we're not varying market level competition. So I don't want to, I tried to say perceived competition, but we're not saying for sure that this is like a competition variation.
And am I interpreting that correctly? That like, I know you said this is a plan that you should choose as, you should never choose, this person should never choose the Medicare Advantage. But if they're very price sensitive and willing to take, it's basically a quality difference, right? So there are many people who that might be worth it for the money, even though it's a lousy plan.
Yeah, so again, skipped this, but in the broker survey that Jason alluded to and I kind of skipped over, so we directly ask brokers to value the different attributes of the Medicare Advantage plan, and then we look at it net of the premium savings and other benefits like dental, vision, hearing, and ancillary. Think of this as a net. So even with the price sensitivity, basically you would have to be like $5,000 a year price sensitive to have the MA recommendation then make more sense.
I just had a quick, first of all, I think it's fantastic, and I remember seeing your grant from Berkeley, and it's just great to see it take shape in this way. I wonder if you know, how are the elderly accessing the brokers? Is it these incessant commercials on television? Who are these brokers? What might they recommend for their own family members? Do you have any information on that? And to the AI question, I think it's going to really matter what the AI is maximizing. But
yeah, thank you so much. For the first question, so we ask, so your question was, do we know what they recommend for their own family? Yeah. So yeah, so we do a survey of brokers ourselves, not the same brokers in the audit. We tried to, a lot of them most of them didn't respond. But we surveyed brokers and we asked, and other studies or other surveys have done the same thing. In other surveys, they found, I think in ours too, we found that a lot of them recommend like original Medicare plus Medigap. In other studies, definitely. In ours, I think it was a little bit more, I think it was still more than half, but I forget the exact percentage. And was there another part? Yeah. Yeah. So, yeah, very good question. And I think that's part of what we want to think more about, the selection aspect and how different brokers are getting matched to different consumers, because we do see a lot of heterogeneity. We did a survey through the Understanding America study that I also skipped because of time, but it's supposed to be a representative panel of the US population, and we ask people how they find their brokers, and it's really a bunch of different methods. So some people find them on TV advertisements, mailers, cold calls. So sometimes these brokers will just cold call people on the phone, and a larger I think it was something like 16%, but it was a larger share of people enrolled in their Medicare plan from a cold call than I would have expected. And then some of it's through referrals or friends and family networks. So there's a wide range of options.
Okay, yes, okay. First of all, I just wanted to follow up, well, both of my questions are follow-up on Marcela's, but first, I agree that I think once we introduce advertising into AI, there's going to be kind of, potentially similar incentives. The second, also similar, I'm wondering how individuals, and you sort of just answered this, but how individuals get assigned to, individuals are not randomly assigned to brokers, and I'm thinking about how, is volume an issue? If like volume is another way that they can kind of maybe they don't make the maximum amount of money on each call, but they're kind of trying to operate on volume. And so, are these people sitting in call centers and just getting there's people on hold and they're just picking up the phone every 30 seconds? Is it somebody who's sitting in their house and once every few hours they pick up the phone and they have a bunch of time to kind of just discuss, with older people like to chat on the phone, so is there kind of this I don't know exactly how to phrase this, but I'm wondering if volume is another dimension on which they're trying to maximize volume of calls.
Yeah, no, that's a good question. I guess one way we try, kind of the volume point, but we do call brokers from call centers and from the largest directory of Medicare insurance brokers in the US, which is an online directory. So we have a mix of people who are just sitting at the call centers answering phone calls every day. And then we have some mom and pop people or smaller firms or larger firms. So we have a bit of a range. We definitely see more MA recommendations from the call center brokers. Part of why that might be happening, and talking to brokers, and we went to a broker convention and just talked to a bunch of people, it seems like a lot of call center brokers are just trained on one product. And we have this in the transcripts that some people will say, oh, I don't know anything about this other product, I just do MA. Or some people will say, oh, I don't know MA, I just do Medigap. So I think that's part of the reason. But yeah, I think that's the best way. I don't know if we have a good way of thinking about the volume other than just what firm they're working at.
I'm thinking about,
sorry.
I'm thinking about from the perspective of the experimental design. So implicitly, we're thinking about the control arm here to be perfect advice in a sense. And I wonder if you have a notion of if these people were not given brokerage help, what would have picked? Would have picked even worse MA plan, and in other words, could it be possible that it's welfare enhancing even with biased brokers versus if they made decision themselves or they just AI themselves and whatnot?
Yeah. No, I think great question, and I think that's exactly what we're thinking in terms of the follow-up work with. If I can click this with the selection aspect. So that's we had originally. We did IRB and we did a pilot of this, basically asking that question, looking at what the consumer willingness to pay for broker advice was and looking at it versus their initial choice quality to see if the people who are choosing well or have a higher demand for brokers and or if it's the people who are not choosing well. From our very, very, very small pilot results, it looked like the people who were choosing well actually did have higher demand for broker advice. But this, again, I think we were kind of thinking about maybe we should put these together, and then we were like, okay, maybe the paper is getting a little long, so this might be a separate thing. And if we make it a separate thing, I think we'd want to do it in a non-prolific, not online population, and we'd want to try to go to a nursing home and make it a little bit more incentivized or something like that. But I think that's a great point to thinking about the overall welfare impact. You need to think about who is choosing to use brokers as well.
Well, that was a great discussion. Thanks, everybody. We're going to go right into the next paper, which Murray Jacobson is going to present. Switching to another program that starts with the letter M, but still keeping with all the various ways in which access happens. So seekers and all that, this is now access in the skilled nursing facility, Medicaid in California.
Excellent. Thank you so much. Thanks for having me on the program. This is also another audit study, but here we're looking at skilled nursing facilities and their decisions to kind of proceed with the admissions process for people based on their insurance status. So we're looking specifically at Medicaid in California, which is called Medi-Cal. And we have there's a long list of people who've contributed to this work, including Erin Duffy, who is in the back there, so you can ask the hard questions to Erin. So we were really motivated by kind of personal and professional experiences trying to get people access to skilled nursing facilities and realizing that Medicaid was a real barrier to access. Skilled nursing facility, probably most people in this audience know, is kind of a setting where people get discharged after a hospitalization when they can't safely discharge home and need supportive care for rehabilitation, physical therapy, and so forth. And about 10% of hospitalizations in the US actually result in a discharge to a skilled nursing facility. And the way this usually happens is actually a social worker will come to the family and the patient and give them a list of facilities and say, tell me which ones are of interest. So this is really a market where there's shopping by consumers, and in fact, Medicare encourages patients and families to shop around. Most skilled nursing facilities accept both Medicare and Medicaid, so like 98%. 95% really have ratings for both of these types of patients, and they also provide both, the same facilities are providing both short stay post-acute care after hospitalization and custodial care. So you should think about them as providing both types of care. So although most facilities are taking both Medicare and Medicaid, anecdotally, as I told you, there's kind of a strong suspicion that there are persistent access problems for people with Medicaid. And so we're going to do an audit study to try to just look at this kind of insurance payer source of difficulty. Just to highlight, again, what we think is the issue here, there are really large payment differences between Medi-Cal, or California Medicaid, and Medicare. So these depend on the particular patient for Medicare, but we're thinking about a low acuity person. A SNF in California would get about $325 a day, and nearly double that for the same patient in Medicare. So kind of all else equal, you'd prefer that Medicare patient. There are, of course, other potential, sources of difference and why you might not favor a Medicaid patient. So there are often concerns by SNFs that a patient kind of converts from a short stay to a long stay patient, and a long stay Medicaid patient is financially undesirable for those facilities. There are also administrative barriers with Medi-Cal or with a Medicaid, which is overwhelmingly a managed care system, so you have kind of limited networks and prior authorization and referrals that might make a patient less attractive. And so we're using an audit study to try to isolate this insurance type effect, and I'll get into that a little bit more when I tell you the next slide, kind of what we do. So we do an audit study of all the skilled nursing facilities in California. We had callers who were, for the most part, college students calling on behalf of their parent who is looking for skilled nursing placement for their parent. So they're calling on, it's a grandchild calling on behalf of their grandparent. And the general script is that the grandparent had hip surgery and needs placement in a skilled nursing facility. And we randomized whether that patient the grandparent had Medi-Cal alone or was a dual patient, so had Medicare and Medi-Cal. And we did that for a few reasons. One is because they're both Medicaid patients, they have similar financial status. So we're kind of holding fixed kind of the expectations about that patient, as well as this idea of converting to a long-stay patient. So both of them would convert to long-stay Medicaid patients, and so we're kind of holding that fixed. We also just had tried different kind of thinking about different secondary insurance, and it was just easier to choose one. So we're doing this, again, dual Medi-Medi and Medi-Cal only. And our main outcome here is, did the facility, the admissions coordinator, indicate that there was a bed available and that the grandchild should tell the hospital to move forward with the process of referral? So tell the hospital to refer the patient. And so what we're not looking at in actual placement, and so we're getting around any network problems. For example, we just want to know, is there the possibility of a placement? Our primary analysis is an intent to treat. We were actually pretty successful, so we found about 75% of the SNFs were reachable, but for those unreachable facilities, we code them as not having beds available, and actually I'll show you, we can also code them as having beds available. We find very similar size effects. It doesn't make a big difference in what we're finding here. Okay, this is just a quick table to show you that on most dimensions, so ownership, bed size, occupancy rates, quality ratings, our randomization was okay, so they're balanced. Unfortunately, there was a little difference in the reachability, so we were slightly less likely to reach the SNFs that were randomly assigned, so not huge, so something like 4 or 5 percentage point difference in reachability for the Medicare, Medicaid patients. Again, we deal with that with the intention to treat. So we're coding them as not having beds available. This is really our main finding, our intention to treat. We see if you called a SNF and you had a Medicare, Medi-Cal, Medi-Medi patient, about 62% of the time they said a bed was available, you should move forward with this process to see if there's a match. And that happened only 38.4% of the time, so about a 24 percentage point gap. This is adjusted by just very basic caller fixed effects and date of call, hour of call, and county, just so you know, but none of the adjustment matters in this context. If we code it completely oppositely, so we say if you were unavailable, you in fact had a bed. And remember, this could matter because we find that slight difference in reachability. It really doesn't matter for this outcome. So basically the levels change, so about 90% of the time, they say move forward with the process for the Medi-Medi patient, 64% for the Medicaid only, so a gap of about 26 percentage points. So really quite similar, 24 to 26 percentage point differences. We also looked at a lot of heterogeneity here, and actually for the most part, we don't find a lot of heterogeneity. There are 2 or 3 things I want to point out. One is that if we look at CMS's quality rating for short stay, so this is the particular type of stay that we're doing our audit study on, it is the case that the highest quality, those with the 5-star ratings, were more selective. They were more likely to say no to the Medicaid-only patient. We also use, thank you, Amy, the INEV et al. Value-added measure, and we find a very similar thing. If you look at the facilities that are kind of have the highest value-added measures, they were also more likely to discriminate against Medicaid patients. On the other hand, if we looked by geography and look at the most rural areas, we found there was no difference in how they treated a Medicaid patient versus a Medi-Medi patient. So I'll come back to this as I think about how we should interpret these results. So the first thing you should know is that there's pretty high occupancy rates at skilled nursing facilities. You can see the occupancy data over here on the histogram. The average occupancy rate is 89%. A typical SNF has about 100 beds. So they do have about 11 beds on average, but there's not 50 beds to fill here. Given this constrained capacity, in a lot of cases, they're interested in waiting, right? And so we find in fact, in the non-metro areas where there's kind of lower occupancy and presumably lower arrival rates of any types of patients, that's where we actually don't see this difference between Medicare or the Medi-Medi patient and the Medicaid only. So really, this is a story about kind of tight capacity constraints and SNFs kind of willing to wait and not fill the bed for the arrival of a patient that pays you double or more per day. Is kind of how we interpret what we've found here. We also did some kind of back of the envelope kind of supply elasticity estimates, where here I should say what we're calling supply is really a kind of effective supply of like, was there a bed available indication here, or the willingness to kind of initiate the admissions process. And just kind of, there are multiple ways to think through this, but let's just ignore costs and think about the change in bed availability and change in payment. We get a supply elasticity of 0.7. That's obviously not right because it's about the net payment, the kind of profit you make from these patients. So we can assume Medi-Cal just covers your costs here. That's actually how California tries to estimate these payment rates. And there we get a supply elasticity of about 0.4. And really, this is just meant to give us a feeling of how we should think about what would happen if we raised the Medi-Cal payment rates closer to Medicare. And I think what this suggests is that even a partial kind of payment increase could go a long way in improving access. So in my quick review of this, what we find here is that these there is, as we suspected, and consistent with a large literature on differences in access for Medicaid patients, although largely in the outpatient setting, that there's this 25 percentage point differential access to skilled nursing facility based on admission response for patients with Medicaid in California. On the flip side, we were actually delighted to find that Medi-Medi patients seem to have much better access. So that was kind of a positive spin on our findings. This pattern, we think, is consistent with facilities responding to kind of the reimbursement incentives under capacity constraints. And our back-of-the-envelope calculations suggest that even small changes that are probably not going to come anytime soon would increase access considerably. So thank you.
So we're going to jump right to audience questions. This is one of the shorter presentations, so please raise your hand if you've got a question. Bring the mic over.
You may have said that, but what % of patients in California have dual coverage versus just the Medi-Cal?
That's a good question. I'm not sure. It's pretty high. So Medi-Cal is something like 1 in 4 Californians have Medi-Cal. So I'm assuming that it's true for the Medicare population as well, but you'd have to multiply that out, yeah.
You had mentioned that 89% of the beds are filled in these. And they're waiting to have a higher paying patient perhaps. So does that, maybe you cover that in the heterogeneity, does that differ by what share of their 89% is Medicaid versus Medicare? If there is a SNF that there is unlikely to get a Medicare patient, are they more likely to accept?
So I think a lot of the patients are going to be Medicare patients in a skilled nursing facility. So that's kind of one thing to just note. We look at the differences by the share of Medicaid patients you treat, and we don't find much difference there. I know that's surprising, and I glossed over details. This is actually stratified, randomized within terciles of your Medicaid share. So we try to balance on that, but. Yeah, I think you should think about the modal patient probably as being a Medicare patient in the skilled nursing facility. Yeah.
Were these patients, was there a signal of the age of the patient? Were they over 65, under?
Yeah, so we explicitly told the students to be kind of vague about this. Okay. It is the case that, Medicaid, not having Medicare is going to signal that you're probably under 65, although in California, there's a sizable kind of immigrant population that is older and not eligible for Medicare based on their history, their work history.
That was the concern, is that if they're over 65, they don't have Medicare, it's signaling
Yeah,
maybe other troubles.
They didn't respond about that, and actually, we had very few facilities that even kind of inquired about that.
Hey, Murray.
Yeah, hi.
Just quick question. I wonder if within California, if you ran into this issue that depending on where you are in the state, like virtually all Medi-Cal recipients are in some kind of managed care.
Mm-hmm.
And I don't know if maybe the SNF rates are carved out and it's kind of common, but I don't know if there's big heterogeneity across like Cal Optima in Orange County and
Yes.
LA Care in Los Angeles, and whether that was a kind of confounding
So
factor.
in principle, the managed care organizations are able to pay more than the Medi-Cal rate. Is that kind of?
You mean the Medi-Cal managed care plans?
The Medi-Cal managed care plans are able to pay more than the Medi-Cal rate that I showed you. So
Yeah.
in principle, they could. I don't know. I mean, again, we tried to get around any network issue by just saying
just fee for service.
Well, we just didn't say anything. We said, we don't know. This is a grandchild calling.
I see. Okay. Yeah. Right.
We have to, and we were very intentional about this. Like, we just want to know if we should move forward with this process, because we wanted to abstract completely from this issue of networks. We just wanted to know, like, is this a, like, yes, we'll consider Medi-Cal? And remember, everyone in our sample, they accept Medicaid patients. So.
Right.
Yeah.
They say they accept Medicaid.
They accept
patients.
Medicaid
Yeah.
patients, and I mean, we can measure, we have it in our data, what tercel they're in, and most of them do actually. It's very rare, I think, the facility that has 0.
So just one thing I would just say,
Yeah.
like one thing you could like look at in the future, like related to this, is whether the SNF payment generosity is related to enrollment rates in the state. Like California is almost the gold medalist with respect to the share of its population on Medi-Cal. So it's 38% actually, 15 million out of 39 million Californians are on Medi-Cal. Whereas, well, not surprisingly, Texas is 13%. Like, and maybe though Texas is much more generous on its reimbursement, and whether that has, if you wanted to expand this.
If you wanted to do it, yeah, I should say,
might be the case that
we had
payment
funding from a
variation-
California institution for
I
this,
see.
so this is all California focused. But yeah, I mean.
Yeah, no, it's great. It's super interesting, yeah.
Yeah,
It's
and
great.
you're right, I should have said 1 in 3, not 1 in 4. Thank
Yeah.
you for, yeah.
What did the script say about the likelihood of staying a long time in the nursing home, as opposed to just,
Yeah.
short stay,
actually
in for a
have
week and then likely to be gone?
So we didn't really say much about this. We just said she had the grandparent, and I should say we randomized gender, which turned out to not, or sex, because it turned out not to matter because we were worried about sex segregated rooms. But we really were vague. She had, my grandparent had surgery after breaking his or her hip, and we just need a placement. So there was no clear indication.
Okay, so this actually partially answers my question, because I was going to ask whether even the Medi-Cal patients were coming from acute care. It sounds like yes. So
Yeah.
how is it that, like, I guess I would have expected then, if I were like a facility manager, my first question would be, okay, great, they're Medi-Cal eligible, but they're coming from the hospital. Is the first part of their stay going to be Medicare? Because typically post, like, for most, they're like patients that are under 65 going to nursing home, that's relatively rarer than the Medi-Cal patient who's also a Medicare enrollee, where the first X weeks of their stay are going to be covered by Medicare, and then they're going to transition to Medi-Cal afterwards.
Well, so we have a script where it's Medicare and Medi-Cal, and then we have ones where we just say the patient has Medi-Cal. I don't think we had anyone where they said, I mean, Erin, you can tell me if I'm wrong, where they said, oh, they have Medi-Cal, do they also have Medicare? Like, that was kind of understood
Like,
When-
it wouldn't surprise me, given the distribution of age of nursing home patients, if they just assumed the person was also Medicare eligible for their initial component of their stay. Like, I guess, do we know in the
then-
data what the frequency
So you'd
is of?
expect to find a much larger effect.
Yeah,
than
like you
this?
might actually have a understatement of
yeah.
the size of the effect, and
Yeah.
then like, especially given that your measure of success is simply that they tell you to apply.
Yeah,
Um,
yeah.
Like, I think in a lot of cases, I've been told by facility managers that the way that they implicitly reject is they take the application and they just put it in a drawer that never gets opened again.
Yeah, I mean, part of the motivation for this was I was calling on behalf of someone else, and they said, I saw Medi-Cal, and it was a non-starter. And I was like, oh, you're not supposed to say that. So yeah, they do put it in a drawer, but that suggests they understand there are some patients who are Medi-Cal only. Anyway, it doesn't really matter. It could be bigger.
Usually those patients are not coming from post-acute. Those are patients are coming from the community. So like, the script I was expecting was, these are both 70-year-old patients. There's the patients that are going to be Medicare only, they're not Medi-Cal eligible, you expect them to go home. And then there are the patients who are, there are three types. Then there are the patients who are Medicare going to transition to Medi-Cal, and then there are patients who are from the community and going to be Medi-Cal only because they didn't have a qualifying hospital stay before the start of their SNF stay.
Well, I'll take it that this is a lower bound, but
It's
I mean, I think
definitely a lower bound.
I think the story here, these are patients who can't go home. And so they're, anyway. Any other questions? Yeah.
It's part comment and part, I'm just wondering if you have some hypotheses, but I think one of the most striking results was the difference based on the quality, the star rate. I mean, I'm very, suspicious of star ratings always, but also the value added
added
measure,
yeah.
which suggests one way you get those measures, and maybe we should be suspicious of those too, is by changing your denominator, right? If they're keeping up.
I read those also as probably capacity/arrival rate stories. So if I have a high 5-star rating, people are probably calling me first, because that's one of the things that's pretty easy for me to observe. And so they're willing to hold out, is how I interpret that result. But again, that's storytelling perhaps at this stage, but yeah. Okay, I believe before lunch, there's another.
Yes. Oh, first though, applause, because that was fantastic. So before lunch, we want to do a couple of things, and one, I want to first acknowledge a lot of research in aging is very central to the mission of the National Institutes for Health. And so we've asked John Phillips, who's from the, he's a special advisor to the director at NIH, to come and make a few remarks if he might be.
Hi, everybody. Nice to see you all. I just wanted to briefly update you on a bunch of things that are going on at NIH around economics research. Many of you who are, I could? How's this? All the way, oh, I see, I'm on the thing. Want to take this mic then? Sure. Oh, now I'm on the camera. All right. So as you probably have seen, many things have been evolving and changing with regards to science policy at NIH. So I wanted to kind of give you a brief update on some of those things, particularly the ones that relate directly to economics. My major message to you all is to communicate with me and with your program officials. A lot of these things are actually evolving, right? So to make an example, one of the first things I'm going to talk about, many of you may have either firsthand or thirdhand heard about the comments that were made by the director of NIH with regards to the scope of NIH science, and in particular, of course, that would relate to health economics, relating to what I'll call, in large quotes, policy research. One of the things I want to kind of help reinforce in this is that NIH, of course, continues to want to get economic research that develops evidence to help improve population health. A concern that has kind of grown over time has been that the research that we support, we don't want it to be considered advocacy. Now, to be clear, we've never supported advocacy in research. It's illegal to do that in grant support. However, oftentimes research is construed in such a way, particularly in the significance section of projects, in such a way as to suggest that they're supporting a particular policy outcome, okay? So one of the things we wanted to do in the context of trying to make clear to everyone involved that this is evidence building and not, policy advocacy or any suggestion of what policy is a good policy or a bad policy specifically in our research, is to establish stakeholders. In other words, identify who are the communities that we're attempting to make evidence for. And the one that has kind of gained the most sensitivity is evidence for legislators, right? So if you're trying to build evidence for public health, for hospitals, for patients, et cetera, that's all fine. But saying things about developing evidence for legislators is a sensitive thing. It is not inappropriate if your research addresses a number of stakeholders, including legislators. The issue is if the research is primarily serving legislators. Every person I've spoken to about this has questions about how their project connects to these things. I strongly encourage you to contact us so we can help you walk through this. We're evolving on this as well. It's also worth noting that while the director made these comments in two meetings, one at the ASH Econ meeting and once again at NBER's meeting where there's actually a slide deck that was done for that, none of this is actually translated as of yet into formal guidance. That information will be forthcoming. So again, that's why it's important to stay tuned and work with folks, okay, at NIH. And again, first person to stop with me is me. And again, my email is simple. It's john.phillips@nih.gov. I can help you answer some of these questions, and more importantly, I can then connect you with the appropriate program official for the research that you're doing. A couple of other quick things. Many of you may be looking for specific notices of funding opportunity to apply to, and notice that they're basically in what's referred to as a forecasting status on NIH's website. There's a backlog of getting these things approved. You may have heard that there's a desire to have fewer specific calls for research, having more open calls and having more investigator-initiated research. In other words, fewer things where we say we want you to do this, this, and this, and instead establishing the mission and effectively letting the research community come to us with their best ideas. That's leading to a very heavy review of which notices of funding opportunities we really need in order to be able to accomplish this. We're really trying to cut back on this and make it easier for folks to effectively apply and get review and award determinations. So if you're waiting to submit something connected to a specific NOFO, of course, the first thing, notice of funding opportunity. The first thing to do, of course, is to check the NIH website where you can see the status of that notice. The second thing to do, of course, connect with your program official and learn whether or not there's any kind of an issue or if there's an alternative. In some instances, you might be able to submit the thing you're looking to do for a different announcement. Okay, you may have heard that one of the things that has changed and is going to be consistent across NIH ICs is what's referred to as the unified funding strategy. So historically, NIH ICs had a bit of flexibility with how they made decisions about what grants that they funded. Now we're trying to do it where the same approach is taken by all ICs. And the key thing I think to take away, particularly a lot of the folks I know in here are funded by NIA. Historically, NIA had what was referred to as a pay line, which meant that if your grant scored at a certain percentile and that percentile was listed on our webpage, odds were good that you were going to end up getting an award. That's going away, and it's being replaced by a system that accounts for a combination of scientific review and program priorities, okay? So basically what we're trying to do is create more opportunities and hopefully in a more transparent way for things beyond just the scientific review to account for why awards get made. So to make an example, and many of you probably are familiar with this from having discussions with program officials, sometimes program officials will seek to use discretion to move certain awards that otherwise wouldn't be paid into the pay line. And why do they do that? Because the topic is covering an area that was of high priority, that wasn't actually going to be captured in the existing funding line. Or there's a new initiative or concern. I mean, think of all the things, for example, that we paid during COVID. So anyway, it allows basically for the ICs to take both review and other characteristics into account when making a funding plan, and then they're going to be held accountable for that. If you're interested specifically in how this works, there's a public webinar on this. You can get information on NIH's website. It's on Friday, August 14th. If you have any concerns about how this process works, I encourage you to check it out. Last quick point, many of you, through your grants, receive support for CMS data. One of the things that NIA used to do was they would say, look, if you're going to apply for CMS data, don't ask for those funds. We have an arrangement with CMS. We're going to pay for it. That way we don't have to cover indirect costs for your award, and that's how we're going to do this. So you could have notified, hey, this is what we want to do, and we would handle it through our system. That is ending, okay? So if you have an award, and the award has already been made, nothing to worry about, okay? If you have an award pending, or your award is up for renewal, I don't mean renewal like a competitive renewal, I mean like the annual renewal you do when you submit a progress report. Contact your program official in advance of submitting your progress report to find out about what you need to do to make sure you're covered for your CMS data, okay? I don't know if there's time, but I can answer any questions you have. We do have time. And I just, again, reinforce, please contact us if you have questions. I know there's a lot happening, a lot changing, moving fast. Again, I think I just want to encourage, and I hope that became clear in all the instances where our director has come and spoke to this community. We are very interested in continuing to have economic research supported in NIH. So thanks very much for your time.
Thank you, John. And you'll be around during lunch for questions?
Yes.
You'll be around,
Yeah.
so I think,
I'll be
okay.
around until Thursday night.
All right.
Yeah.
So I'm going to take it that we'll do questions over lunch, or if there are burning other questions, because we do want to also take a few moments for something very important. As we know, John Skinner.
I will just say, one of the key lessons about managing the NBER, things like that, is don't assume people read their emails. What we're about to do is just old news for many of you, but just to remind those of you who were gathered here at Summer Institute, but were not with us at the spring program meeting of the aging program, after a decade in harness as the program director, John Skinner is stepping down, and effective September 1st, Kosely will be the director of the NBER aging program. It was not, I will point out, John's idea that we should do another tribute to John today, but there was a groundswell of public demand to do this. So I'm going to hand the microphone to Kosely in just a second, but I just want to remind those of you who've been part of the NBER gathering here at the Summer Institute and the aging program for many years, when John took up this role, he was succeeding David Wise, who was the founder of the program, who'd been such an architect of not just aging economics here at the NBER, but I think one could arguably say David was really a proselyte who had helped the whole field of the economics of aging get off the ground. So I didn't quite say this when John was taking this on, but it was a really big set of shoes to fill. And over the past decade, John has done an extraordinary job of doing a whole host of not just exciting research things within the program, but also management issues. For example, the spring aging program meeting was an innovation of the Skinner Watch. The diversifying the set of people who were organizing the program meetings was a thing that was a novelty that John introduced. And throughout all this, of course, John has led from the front. His at least a dozen working papers over the time he's been in the program director's role have, of course, contributed to pushing forward the research agenda. But he's pitched a very broad tent in terms of the issues that are important, ranging from health and funding issues around health for the elderly population to financial issues to demographic issues and everything in between over this time. So when I reached out to various folks last spring to ask about, when John's stepping down, what will we do? There was a tremendous groundswell of support for Kosalie as the person who would carry this mission forward. Any of you who have been watching her run around this room with the microphone can tell that we are in good hands going forward. And she, who has come off the role as leading ASH Econ, is in the presidential succession to APAM, and is also finding time in her very busy schedule to do the NBER aging program. We are very grateful to her for taking this on. She, of course, in her spare time, is one of the co-PIs on what is the legacy P01 grant here at the NBER, today with Kate Baker on a project which basically is focused on the ADRD and the elderly population, but which traces its lineage back to the Richard Sussman first grant to the NBER with David Wise as PI back in 1986 or 1987. So, Kosalie, we were delighted that you're willing to take this on, and thank you for taking this on. Okay, now the floor is yours. And with that, the floor is yours. And John, you're not done yet.
All I'm going to say is just I recognize what big shoes these are to fill, and I have so appreciated what I've gotten to learn from John and from just seeing what a wonderful community you've built together. And I am just very grateful for there being many people who are going to help me through all this. So please, I will be seeking your thoughts on how we carry this forward together. So that's pretty much all I'm going to say. Because we will have lots of opportunity over lunch to talk about fond stories, and John knows he'll be very much part of all this going forward. So thank you, and we are off to lunch now, I believe. We'll be back at 1:10. Chris is going to get started. Chris Dunphy is presenting the first.
Great, thank you, Cosley. Hello, everyone. My name's Christopher Dunphy. I'm going to be presenting some joint work looking at the association between documented dementia diagnosis and caregiver mental health among Medicare enrollees. I'd also like to first just acknowledge the National Institute of Aging for funding this work. So dementia is a defining challenge of an aging society. In the United States, there's an estimated 7 million people currently living with dementia, a number that is projected to nearly double by the year 2060 due to underlying shifts in population demographics. Dementia, both clinically and financially, is extremely burdensome. It's one of the leading causes of disability and dependence among older adults in the United States, with annual formal costs of care estimated to be around $400 billion. Outside of these direct costs, there's also well-documented costs of dementia to informal caregivers. In the United States, there's around 11 million family members and friends currently providing an estimated 18 billion hours of annual informal care. So because of this, there's been a literature that has developed analyzing the impact of caregiving for those with dementia on caregiver health, healthcare utilization, and finances. And this literature has showed that there are documented physical, emotional, and financial strains from caregiving. However, this has primarily been using survey-based studies. Population-level intra-household analyses are a little bit more limited, which is where our study comes in. Specifically, we're asking a very similar question: what is the impact of a documented dementia diagnosis within a household on the mental health and preventive care behavior of the caregiver, but are really contributing in how we're answering this question? Specifically, we have access to a CMS address crosswalk that we're able to link to Medicare claims data. So within this universe of Medicare claims, able to identify dyads in which there are two Medicare enrollees at the same household. And from this, identify these dyads where there are dementia diagnoses and study these spillovers for these partners. All right, so we think this really helps facilitate a large claim-based analyses on caregiver burden. Additionally, this is a scalable methodology. We'll be able to study other interesting spillover effects within dementia dyads. So how do we do this? As I mentioned, we're using Medicare fee-for-service claims in the year 2011 to 2017, a 20% sample. We're linking in the CMS address crosswalk, which has de-identified address data for each Medicare enrollee. And we follow previous literature that has utilized this address crosswalk to identify dyads of likely spouses or partners within Medicare. From that, we then produce a dementia dyad where one individual within the cohort within the dyad is diagnosed with dementia using the chronic conditions warehouse flag within Medicare claims. The other partner then is defined as the caregiver or likely caregiver and is going to be the study population for this study. One important distinction here is that because we're using claims data, that we are looking at documented dementia diagnoses and not necessarily the onset of the disease in particular. So there's been a lot of research that has shown when we actually observe a diagnosis in claims, it's typically well along the life cycle of dementia. So this is one caveat to keep in mind as I'm showing you the results. We're really focused on spillovers from the documented diagnosis. We then produce several different outcomes split into 3 different categories, first being mental health episodes. We look at depression, anxiety, and insomnia in a combination of all 3. These outcomes are produced using ICD-9 and 10 diagnosis codes, as well as verification with receipt of prescription drugs. We also look at prescription drugs independently, specifically antidepressants and anti-anxiety medication receipt from Part D data. We also have 2 outcomes looking at preventive care, being the number of outpatient visits and annual wellness checks. Our empirical strategy, we use a stacked difference in difference model with not yet treated units as controls. Here is the event study specification, which I've shown here. One additional thing with this is that in our not yet treated control group, we are ensuring that there is at least a 12-month gap between when, for a given sub-experiment within the stacked diff and diff, when the documented diagnosis occurs versus the matched control group. So this is the event study specification. We also estimate this in the standard difference in difference. Our treatment group consists of around 30,000 individuals, and our control group around 34,000. So these next few slides are kind of the main takeaway, I think, from the work so far. So this is looking at the prevalence of any mental health episodes. So this is the combination of those 3 mental health disorders mentioned earlier, between the treatment, denoted by the red line, and the control group, denoted by the blue line, relative to the event time. And what we see is that prior to documented diagnosis among the treatment group, both lines have similar trend and level. Post-diagnosis, they start to deviate a bit, with slightly higher prevalence of mental health disorders among the treatment group relative to the control group. Formally, when we model this in our event study specification, this validates what we see descriptively. In the post-period, we're seeing statistically significant increases in any mental health disorder episode relative to the control group, hovering at about a 5% increase. This plot shows the average difference in difference effects across the various outcomes. Again, looking at any mental health episode, we're seeing about a 5% increase in the treatment group relative to the control group. This appears to primarily be driven from an increase in the prevalence of depression post-documented diagnoses. And we are also seeing some evidence that there's an increase in insomnia, although a bit noisier with higher standard errors. We aren't finding any statistically significant change in anxiety. Looking at prescription drug use, we aren't seeing a statistically significant change in the receipt of antidepressants or anti-anxiety medications. One thing that's important to note here is that because we're using Part D data, these are prescription fills. There may, in fact, be changes in prescribing behavior, but in terms of receipt of medications, we aren't seeing a statistically significant change. And furthermore, we aren't seeing any evidence of a change in outpatient preventive care services. These findings are relatively robust across a set of sensitivity analyses, expanding our months gap for the matching to 24 months, including a 24-month pre-period, so extending our pre-period window, as well as stricter enrollment criteria for the study sample. One of the major threats to validity is that when we observe a dementia diagnosis in claims, it's not random. Our own exploration of this and other studies have shown that oftentimes it's accompanied by some acute healthcare event. So we can think about maybe a stylized example where someone has some acute cardiac event, ends up being hospitalized. While in the hospital, clinicians notice signs of dementia, end up receiving a diagnosis while in the hospital. And so what we want to get a better understanding of is if these spillovers we're finding, are they due to documented dementia, or is it potentially some other confounding acute healthcare event? So to try and get at that, we split our sample into 2 groups based around the setting of the documented dementia diagnosis and what was occurring around the timing of the diagnosis, into an acute event group and in a group in which we did not observe an acute event. And what we're seeing is that the results are pretty consistent across both of these settings. And in fact, when there was not an acute event, we're actually seeing a bit stronger spillover. So we think this is suggestive that these acute hospitalizations are not driving our main findings. Additionally, we ran several placebo tests. So this is modeling different types of conditions as opposed to just dementia. So as we know, dementia caregiver burden is quite high, and if a lot of these effects are due to this burden, we maybe wouldn't expect to see similar spillovers for other types of conditions where the burden wouldn't be quite as high. So we looked specifically at spillovers among dyads where there's lung cancer diagnosis, atrial fibrillation diagnosis, and hypothyroidism diagnosis. And really across the board, we aren't finding too much of an effect of spillovers within these different diagnoses, suggesting what we're finding to dementia is quite unique, perhaps because of the higher caregiver burden. Okay, so to summarize, our findings are consistent with this idea that documented dementia diagnosis leads to elevated prevalence of mental health disorders among caregivers. This appears to be driven primarily via elevated rates of depression. There's some evidence of an increase in insomnia episodes. However, we don't find strong evidence of a change in prescription medication or a change in outpatient preventive care. And what we're finding appears to be unique to the dementia caregiver setting where caregiver burden is high. So thank you for your attention.
Yulia Truskanowski is going to present the next paper.
All right, thank you for having us on the program. I'm delighted to be here to present this work with, which is joint with Onar, who is in the room, and then our colleagues Anders and Jane, who are in Denmark. And this is called Living with Dementia, Mental Health and Mortality Effects on Spouses. So thank you to Chris for that great setup. I'm gonna be able to not spend a lot of time on the motivation here. I just want to emphasize that, dementia is a family disease because of the spillovers, and we think of the spillovers not just in terms of caregiving costs, which are immense, but also, this is a uniquely disruptive disease in the sense that it really erodes cognition, personality, and decision-making capability. And so, when you're thinking about a spouse dyad, it's potentially really just changing the person that you married and changing the nature of the relationship, and that also potentially has mental health spillovers. And this is something that is hard to study because, again, as Chris very nicely laid out, it is not an acute shock that comes on suddenly that is unexpected. This is a progressive, gradual, irreversible disease. And so from an econometrics perspective, that makes it kind of a hard object to study. And yet, that's what we're going to try to do here. So we're going to estimate, very similarly to the previous paper, the effect of ADRD on a spouse's mental health. Our approach here is going to be a little bit different. We are going to center our event study on the death of the patient with ADRD rather than the diagnosis. And the other big difference is that we are in Denmark. And that is relevant because the Danish context is very different. The healthcare system is very different. The long-term care system and the availability and affordability of formal care is much greater in Denmark than in the US setting. So we're going to be focused on a treated patient with ADRD and their spouse. Which is a patient-spouse pair. And we're going to follow the spouse over a 17-year window, starting 11 years before the death of the patient and up to 5 years after. Okay, so in order to tease out the effects of dementia, we are going to have two different counterfactual patient-spouse pairs to compare to. So the first is a placebo pair. So this is where the patient never develops ADRD and does not die in what we're calling year zero, in the event year. And we're, again, interested in the outcomes of the spouse of that patient. The non-ADRD pairs are going to be a patient-spouse pair where the patient does die in the same year as our treated ADRD patient of interest, but not with dementia and has never been diagnosed with dementia. And again, we're interested in the spouse's outcomes. Okay, and so the comparisons we're going to be making here, just to be very clear, is ADRD versus placebo. So this is the effect of a spouse dying and then also having dementia. Non-ADRD versus placebo is the effect of a spouse dying without dementia. So there could be spillovers from other illnesses, other caregiving needs. It could be an acute shock. And then the difference between those two lines or those two trends is what we're thinking of as what is specific to dementia. Okay, so one thing I have to mention before getting to the results is that we're going to have a lot of attrition by mortality in this sample, right? So the patients here are on average 80 years old. Their spouses are similar. So a lot of the spouses themselves will die over the course of the study. And we're interested in this for two reasons. One, if the attrition is correlated with the outcomes that we're interested in, so poor mental health, leads to increased mortality. We might have some kind of underestimation of the effects, right? But also there is a literature that looks on the bereavement or the widowhood effect, so this idea that the patient's death might actually impact the health or the mortality of the spouse, and that's something that we want to see if we can kind of think about carefully in this context. Okay, so first, just mental health care use. I'm going to show you first ADRD versus placebo. So just to orient you here, so this is an event study. This is 4 separate event studies starting 11 years before the death of the patient who dies in year 0
where that dashed line is, up to 5 years after that death. And then the trend that you're observing here is the mental health outcomes of the spouse. The first column is outcomes for men. So this is where the spouse is the man and the patient who dies with ADRD is a woman. And then the next column is where the spouse is a woman and then the patient with ADRD who dies in year 0 is a man. On the first row, you are looking at mental health visits. So this is a mental visit to a general practitioner for a mental health reason, a psychiatrist or a psychologist. And then the second row is prescription medications. And so I think 2 things are notable right away. The first is at year 0, you have this big spike up. So, there are mental health spillovers of having a spouse who dies. And we're looking here at the ADRD group versus placebo, right? So the counterfactual here is the spouse does not have a patient who dies in year 0. And so you can see this big spike up with a return kind of to counterfactual, some persistence for psychiatric medication use, but also this ramp up that starts well before the death, right? So it looks like mental health spillovers begin as early as 8 years before the death of the patient with ADRD. Okay, now I'm gonna layer over this the same event study, but in red here, this is the non-ADRD to placebo comparison, right? So the red triangles here are spouses where the patient does die in year 0, and you can see that there's that big increase in year 0 in mental health care use and in prescriptions, right? But that patient did not have ADRD, and so there is not this similar kind of increase in mental health care use that starts well before the death. And so we're interpreting that difference as what is attributable to the spillover specifically of having a patient with dementia. Okay, so we've done some heterogeneity here. We don't see any difference by age, by number of children, by household wealth. The only difference that we see, and I've tried to cram a lot here, so it's probably hard to see, but the only difference we see here is by whether or not the patient is in a nursing home. Amazing. So we see a larger increase in mental health spillovers among spouses where the patient is in a nursing home or has spent time in a nursing home before death. And what that suggests to us is that maybe nursing home use is a proxy for severity, right? And so you might think that a more severe illness, more severe dementia has kind of larger impacts in terms of mental health on the spouse. And it also potentially shuts down the caregiving channel because a spouse who is in a nursing home, and again, remember we're in a Danish setting, not a US setting, a spouse that is in a nursing home potentially needs less care, less physical hands-on care than a spouse who is being cared for at home, but is potentially more severely ill. So that suggests to us that it's not necessarily the hands-on caregiving that is having the mental health spillovers. Okay, just to kind of summarize these results, we see this gradual increase in mental health care use starting as early as 8 years before the death of the patient. And now that does include some dementia-related diagnostics and treatment. So some of that ramp up, especially for men, and I'm not showing you the figures, is men getting their own kind of diagnostic workup and potentially getting treated for dementia itself, but it's not entirely, doesn't entirely explain that increase. And we see as much as an 82% increase in mental health visits and a 12% increase in psychiatric medication use among men in the 5 years before the patient's death with dementia, and then 68% and 10.4% for women, just to put some magnitudes on those increases. And it's larger for patients with significant care needs, which we're proxying right now by looking at nursing home use. Okay, so I mentioned mortality in the beginning. So this is those same figures, but now we're looking at mortality. So this is the outcome here is survival up to that year. So you have men, again, on your left and women on the right. And so in particular for men, we do see some differential mortality, and the trends look different. So we see an increase, or a decrease, rather, in mortality relative to the counterfactual among male spouses, and then a sharp decrease, which suggests, there could be some relationship between the death of the patient and the death of the spouse that is dementia-related. For now, we have tried to address what we think could be the kind of differential attrition kind of selection issue a number of different ways, including balancing the panel, using Lee bounds. And broadly, we see very, very similar results no matter what we do. There is always this increase in mental health care use in spillovers that starts well before the death of the patient with dementia. Okay, so just to conclude, the patients, what we've shown here is ADRD progression has significant mental health effects on spouses. It's ADRD specific. We have looked at a number of physical health outcomes. It is not driven by kind of just broad healthcare seeking behavior or any kind of inpatient, outpatient, acute care needs. It is really concentrated in mental health care use. And it is robust to selective mortality-related attrition. And these increases in mental health care use do include increased screening and medication for dementia and related symptoms. Differential mortality is present, in particular for men, and so that's something that we are looking forward to investigating next. So I will end it there. Thanks so much.
Eldon Chang is going to present the next paper.
Okay, hi everyone. Thanks for having us on the program. I'm excited to present my work with Martin on peer effects among nursing home roommates. I'll start with some motivation. In the US and in the OECD more broadly, several demographic trends pose significant challenges for long-term care funding. These two panels show that the share of the population above 65, as well as the population living with dementia, or ADRD for short, is projected to rise sharply in the coming decades. Elderly individuals often require long-term care, especially if they suffer from some form of cognitive impairment. So these trends suggest that demand for long-term care is likely to increase significantly in the near future. This places long-term care spending on an unsustainable trajectory, with annual spending on nursing homes in the US already exceeding $200 billion today. Now, we might think that this is money well spent if the elderly received exceptional care, but the sad reality is that despite heavy spending, patient outcomes are often poor. 15% of nursing home residents die within 90 days of admission. 1 in 3 post-acute nursing home stays results in adverse events, and 4 in 5 facilities face staffing challenges. Reasons for this include low reimbursement rates, asymmetric information, and gaming by providers. Traditional levers for improving quality, such as increasing staffing or wages, tend to be expensive, potentially adding to already high costs. Therefore, it is imperative to find cost-effective ways of increasing quality in long-term care. This leads me to our main research question: can better room assignments improve patient outcomes? We focus on room assignments for a couple of reasons. Most nursing home residents share rooms and stay in close physical proximity for extended periods of time, yet little is known on how these interactions shape outcomes. In addition, room assignments are a relatively low-cost policy margin, unlike the quality levers I mentioned on the previous slide. So to answer this research question, we proceed in 3 steps. We start by estimating the causal effect of room assignments on patient health. Specifically, we'll be comparing 3 types of room assignments: being assigned no roommates, being assigned a roommate with ADRD, and being assigned roommates without ADRD. Next, we test whether these effects vary systematically across patient types. This is important because without heterogeneity, room assignment policies are essentially zero-sum games, at least at capacity-constrained nursing homes. Finally, we use these estimates as inputs into an optimal room assignment model to quantify potential gains from better room assignment policies. For our analysis, we combine rich administrative data from the minimum data set with Medicare claims data covering 2.5 million first-time nursing home stays across more than 7,000 nursing homes between 2000 and 2010. This data includes information on patients' room assignments, health conditions, as well as their mortality outcomes. We also use this to construct a novel daily panel of room occupancy and availability for each room in every nursing home in our sample, as this figure here illustrates. Moving on to our research design, here is a causal equation linking patients' 90-day mortality to indicators for being assigned to an empty room or being assigned a roommate with ADRD. The omitted category is assignment to a roommate without ADRD, and we also control for nursing home by year fixed effects, as well as capacity strain and overall patient composition at the nursing home. The key challenge for identification is that room assignments are not random. For example, we see in our data that patients with ADRD are more likely to be assigned roommates who also have ADRD. Therefore, we use an IV strategy that leverages variations in room assignments that is driven by the types of rooms available at admission. Specifically, our instruments are the share of available rooms at the time of the focal residence admission that are empty, as well as the share that is occupied by a resident with ADRD. For these to be valid instruments, they need to satisfy three conditions: the first stage assumption, conditional independence, and the exclusion restriction, as well as this third assumption, which you can think of as the extension of monotonicity to IVs with multiple treatments. In the interest of time, I'll focus on the first two assumptions, but I'm happy to answer questions about the third offline. Here is a figure showing the first stage and balance test for one of the instruments. On the x-axis, we have the instruments, which is the share of available rooms with a resident that has ADRD at the time of the focal residence admission. The blue line shows that the instrument strongly predicts whether the focal resident is assigned a roommate with ADRD, with a first stage F statistic exceeding 20,000. At the same time, the red line shows that the instrument is uncorrelated with baseline mortality risk, which we define as predicted mortality from a ridge regression using more than 500 predictors constructed from baseline characteristics. This first stage and balance test looks essentially identical for the other instruments as well as in subsamples, and balance tests for additional baseline characteristics are also reassuring. Moving on to results, this table shows our main peer effects estimates. In the first column, we see that on average, what's best for survival is to be assigned no roommates, whereas what is worst is being assigned a roommate with ADRD. These effect sizes are large. Moving from the best to the worst type of room assignment increases 90-day mortality by 1.1 percentage points, which is at least half a standard deviation in between nursing home differences in value added. At the same time, the next two columns show that these effects vary sharply across patient types. In column 2, we see that for patients with ADRD, the best type of room assignment is the omitted category of being assigned roommates that are cognitively healthy, whereas what is worst is being assigned roommates who also have ADRD. By contrast, the last column shows that cognitively healthy patients benefit from being assigned to a private room, but conditional on having a roommate, the type of roommate they are assigned does not really matter for their survival. A potential mechanism that explains these asymmetric effects is that cognitively healthy patients can potentially play a support role for their roommates with ADRD. If this is the case, we would expect this peer monitoring role to be particularly valuable in nursing homes that are understaffed and that do not have Alzheimer's units. And that is exactly what we find in additional heterogeneity analysis. Our results hold up under a host of robustness checks, but this is probably too much to digest so soon after lunch. So I'll skip this and tell you some results on alternative room assignment policies. So using a simple optimal room assignment model, we find that the optimal rule for minimizing overall mortality prioritizes mixing patients with and without ADRD as roommates. This figure shows simulated 90-day mortality as a function of the share of nursing home rooms that are private under 3 counterfactual assignment rules. We see that simulated mortality is lowest under the optimal rule, followed by random assignment, and highest under a segregated room assignment policy. In addition, the vertical line shows that at the empirically observed nursing home room composition in our sample, the optimal rule reduces 90-day mortality by 0.6 percentage points relative to the status quo, a difference that is 4% of the average mortality rate. We can enrich the model to allow for the assignment rule to place different weights on various types of patients, as well as allow for heterogeneity across nursing homes, and we still find similarly large gains. In summary, we combine rich data with a quasi-experimental research design to produce one of the first pieces of causal evidence that peers can drive large differences in mortality. Zooming out, our findings speak to several big economic questions. First, it relates to a huge question in health economics on why patients experience drastically different outcomes. Here, we provide evidence on a relatively understudied margin showing that patient interactions can drive meaningful differences. Second, we add to a vast literature on peer effects, which has traditionally focused on other settings such as education, labor, and development. We show that peer effects also matter in inpatient settings for a high-stakes outcome, and also that it interacts with capital and labor. Finally, we add to a small but growing literature on within-provider variations in quality, on which Diane McWitham has interesting ongoing work on the value of private rooms in institutional settings. We show that within nursing home variations in quality are driven in part by between patients complementarities and also provide evidence on mechanisms. Finally, our results have practical implications, suggesting that room assignment policies may serve as a cost-effective lever for improving quality in healthcare. Just about out of time now, so thank you for your attention.
Okay, first of all, let me thank the authors for this wonderful group of papers that I'm going to try and synthesize under the umbrella of caregiver burden and monitoring frictions in ADRD care. So let me start with thinking about how ADRD care depends on a very special monitoring triad where we have the patient, the spousal caregiver, and the physician or the provider. So basically, think about the patient as the one that, of course, has the symptoms, needs, and responds to treatment. Then we have the spouse that is basically the monitoring agent that observes and interprets, and the spouse delivers, communicates, and coordinates all this information to the physician. The physician, based on that knowledge, is going to interpret, act, and follow up, and create tailored care, and also provide monitoring guidance to the spouse. But frictions can break this loop at every point. So let's think first about observation that connects the patient and the spouse. It could be that the spouse does not know how to detect the changes in patient symptoms or how they respond to treatment. When you think about communication between the spouse and the provider, it could be that the spouse detects the change but doesn't really know how to interpret it, doesn't really efficiently log it in, or is unable to convey it accurately or in time to the provider. And finally, when you think about the clinical response itself that connects the provider and the patient, the provider that received the information may not be able to translate it to patient-tailored care because it could be that the spouse's observations are not systematically recorded, so basically the doctor cannot know what works for this patient. As I see these papers, all of them expose frictions or frictional cost across this triad, and both on the informal care part and the formal care part. So the first paper documents that the diagnosis raises caregiver mental health burden without an offsetting effect, to treat that. Then the second paper shows very nicely the excess caregiving burden that grows with the disease progression until the caregiving stops at death. And then finally, the third paper shows that cognitively healthy roommates improve ADRD survival within the formal care system, especially when the staffing is low. Okay? So together, you can think about the caregiver stress as some frictional cost in the provision of informal care, and the peer effects revealing very bad frictions in the provision of formal care. So let me go through each one of the papers, and then I'm going to synthesize them together into this frictional cost idea. So the first paper, just reminding you, that was ADRD diagnosis and spousal mental health. They find that ADRD diagnosis raises caregiving mental health disorders, mostly depression and sleep disorders. And there's no detected treatment effect in response to that, showing us that the diagnosis raises burden on spouses, which also remains untreated. Now, I think what could be really interesting to look at next is to see whether active clinical follow-through can protect the spouse. So how can you do that? You can think about primary care physician practice styles variation, okay, to study whether the caregiving depression and sleep problems maybe they rise less when providers show stronger response. And here you can think about multiple layers of variation in PCP's post-diagnosis response. For example, how fast the follow-up is, the specialist care that they assign, home care, care management, continuity of care, etc. Then we have the second paper that looks at spousal mental health around the ADRD death event itself. And here they show us that ADRD progression has significant mental health effects on the spouse. So if we're thinking about the focal time being the patient death, the patient that has ADRD, they see that about 8 days before that event, there is very clear ADRD-specific mental health care use of the spouse that begins to rise. Then in year 0, we have the bereavement beginning, but the dementia caregiving ends. And thereafter, it's very clear how they show the convergence between the ADRD and non-ADRD, okay? So together, this really shows excess caregiver burden that ends at death. What I think could be really interesting to see here is to look at whether nursing home can absorb the late-stage burden, and Eula was talking about the fact that it combines both severity and the fact that it could substitute. So I think you can do here some instrumentation, maybe with distance to the nearest nursing home, or some variation that I proposed to the previous paper, or something along these lines. And the third paper shows us the striking result in the context of ADRD and nursing home roommates, where cognitive healthy roommates reduce the 90-day mortality among residents with ADRD, presumably through recognition of patient needs and alerting staff. And we see that those effects are larger in facilities that have less staffing or don't have dementia units. Together, it looks like peer monitoring fills the gap when formal monitoring is inadequate. Now, what I think could be really interesting here is to basically look at papers 1 and 2 and see whether monitoring impose a caregiving burden on the non-ADRD roommate. And here you can look at the other outcomes that the papers looked at, which is mental health, sleep disorder, stress, satisfaction. And here in a context, I think you can also look at room transfers that could look at maybe demand of switching rooms, right? The other thing, and this might be too heavy lift for some exercise like this, but I think given that this looks like it's symptomatic of a suboptimal system, it would be interesting to see it in other contexts. Martin, maybe your Danish connection, you can run it there to see whether you see similar results or not. Okay, so now let me put this together. Basically, what we see is that these papers document large spillover costs of ADRD, and they document those effects, but the question remains is, can better monitoring and more timely tailored care can mitigate them? Okay, so that's an open question. Now, I think that monitoring here can improve care and reduce these spillovers, but it carries frictional costs. So basically what we observe is the second best other caregiving burden and the other constraints. So if we're just thinking of M being monitoring, V of M being the returns from monitoring, C of M being all the costs that involve, including mental health, we basically provide monitoring until as long as V prime of M is larger or equal to C prime of M. Now let me quantify how far we are from a potential first best. I'm going to look at some electronic health records to identify the excess incidence of conditions that are monitoring sensitive and therefore can be avoided if monitoring is more adequate. And I'm going to do that across ADRD patients. So what am I using here? I use Epic Cosmos, which is basically, if you know Epic, the vendor of the EHR, created a nationwide EHR record database that has basically about 50% of the US population. The denominator that I took here was patient 65 or older that has at least one home care or hospice encounter just to proxy for needs so I can compare comparable groups. And within them, I'm going to classify patients based on whether they have ADRD or not, and basically, and also whether they have spouse or not. Okay, the outcome that I'm going to look at is the percent of people that have an admitting diagnosis for a monitoring sensitive condition. And here I look at ICD-10 codes that are related to malnutrition, dehydration, pressure ulcers, infections, et cetera, that could be avoided with better monitoring. All in all, it identifies 1.8 million adults, where about 450,000 of them have ADRD. Okay? The measure that I'm going to look at is the axis between ADRD and non-ADRD incidence, and I'm looking at this non-ADRD incidence to think about is, you know, like what we have like to think about natural unemployment rate, so kind of like a natural failure rate to monitor. Okay? Okay, so these are the results. On the x-axis, you have the percent of the incidence of monitoring sensitive condition. The upper part is comparing by ADRD status, and you see that patients with ADRD are 10 percentage point more likely to experience those events, okay, which is about 80% increase, showing a significant deviation from a potential optimal allocation. And then in the bottom half, I'm taking only the ADRD patients and I split them by whether they have a spouse or not. And what you can see is those that have a spouse have 3.4 percentage point less probability of having that incidence, telling us and then if you look at the bottom, some people would like the results that most of it is driven by women's spouses, okay, it's actually double the effect. And that means that overall spouses offset the gap, but only partially, and in that simple model, you can think about them hitting the marginal cost or the flat of the curve, the V prime. Okay, now what I do here, I take those two gaps, and I just look at the variation across the US just to see if it's systematic or not. And we see that there's a lot of variation. That means that this monitoring sensitive morbidity is not something fixed that you cannot move around, okay? That leaves room for policy intervention, but the question remains is how? How are we going to do that? So what I think is that remote patient monitoring could be a very promising pathway because these gaps are showing us potential gains from better monitoring. And how can we get a better monitoring assist here? You can think, first of all, about all this home care knowledge, the duration, being recognized, interpreted, and communication in a timely manner. This is the first part. And second, by providing efficient logs and communication between the spouse and the patient in terms of how they respond to treatment, that gives the feedback for the physician to design the tailored care. Now, this is something we're doing in the context of cardiovascular risk. We have an RCT called Healthy Heart with the support of the Roybal Center at the NBR. And basically what we do here, we're comparing the first arm, which is regular RPM. People just communicate, they measure the blood pressure, and it goes directly to the clinic. And then we have the second arm, which is AI enhanced. You knew that AI is going to come up in this, Tim, right? This is for you. So we have the AI arm, where basically we're adding this patient-tailored care. And how do we do that? You collect the Y outcome, which is the blood pressure with the cuffs, and then you collect a bunch of X variables that are either coming from questionnaires that you answer or smartwatch, et cetera. And then you basically run regression. Think about it as running regression at the patient level and taking the highest beta, but we just do it with Shapley value, okay? Basically, for this patient, you see that what reduces their blood pressure the most or have the highest correlation is their speed of walking in the last 72 hours, and that patient is going to get this, patient-specific guideline that says, in the past week, your blood pressure was this, which is a reduction, great job, and then we say, here, our analysis shows that your blood pressure is related to your walking speed. So during your activities, try to focus on that, okay? So we can do something very similar in the ADRD world, but there is a particular problem here that the patient themselves cannot be the one that communicates. So the RPM must be designed for this unique ADRD triad, it has to directly involve the spouse as a pivotal member. Okay, now current products that I'm aware of, either directly observe the patient, let's say in dementia units, okay, so you have the direct patient monitoring, or they interact with the caregiver to reduce their stress, but there's nothing that I've seen so far that connects all the three agents, okay? Now what could happen here? If you have well-documented disease progression or deterioration in response to external variation, those axes that I said, you could use that to optimize the patient-specific protocol of care. And there's a lot of room for tailored care in ADRD, in particular in managing person-specific triggers of psychological symptoms, or if you want to help them with ADLs, for example, it's very different what makes one person to eat or not. The setting is very sensitive, so that can be very tailored, okay? So all in all, I could think this could be very promising both for improving the technology, the V prime, and reducing the cost, because that improved login and efficient tailoring could provide the spouse with the clarity they need and reduce some of this burden. Thank you so much.
Open up to questions.
Great papers all around. I had a question for Yulia. Can you look separately, or do you already look separately at deaths after a chronic disease versus like an acute disease? Because it seems to me that like the stress factor is going to be very different in terms of that lead up, that you might see something similar for like COPD or something where you have to help your spouse manage this very tricky disease.
We have thought quite a bit about that, a little bit more in our companion paper where we look at spillovers on children. It turns out most people who are 80 and die do not die kind of an acute shock, at least to the extent that we can see in the medical records. So it was hard. We spent a lot of time thinking about, can we isolate sort of, we've pulled out cancer as kind of like a potential counterfactual, so like where the parent has cancer, where the spouse has cancer, and it looks very much, it's about 30% of the non-ADRD group, so it looks very much like the ADRD group. None of us are clinicians, so we just struggle very, like if people have ideas for how to categorize, nobody like drops dead randomly at 80 without having COPD or something else, or it's a very rare group. So we're struggling with that, but I would love to hear more about that.
I have a question for the roommate guys. I guess, so it's an exclusion restriction question. So you've got the instrument being like availability of rooms with an ADRD roommate. So how do you differentiate between the effect of having an ADRD roommate versus just having a lot of ADRD patients in the nursing home at a given time?
So we control for overall patient composition at the nursing home, so like the share of nursing home residents at the time of admission that have ADRD.
Sorry, I guess like I'm trying to think of what variation is left then if you control for the kind of portion of patients with ADRD in the nursing home, but then the instrument is
so
like
I guess it's a distribution of different types of patients across rooms, and that may vary just because of stochastic arrivals as well as discharges.
I see.
These were great papers and great discussion pulling it all together. So the first two papers have some similarities. Yulia, you could have used diagnosis, I think, as your event time, but chose not to. So I was curious whether you wanted to comment on that. And on the first paper, I didn't know if you have the granularity or I know it's only a 6-year period, but to show kind of the lead up before diagnosis to kind of show what that pre-diagnosis elevated mental health outcomes look like.
Yeah, thanks. Great question. So we did look well in advance and also looked like relative to more clean controls. And so we do see that, and I should mention, we're looking at new cases of these diagnoses and episodes as well. So by construction, at the start of our sample, there's relatively low number of episodes, and it's a continual gradual grow over time. When we compare it to a control group where they are not yet treated, so just like a clean control, we see that there are substantial pre-trends leading up to the actual diagnosis itself in terms of differences in mental health between these groups.
The logic for using death is, it's a well-defined event that's kind of, it's there in the data. It's, well recorded in Denmark. We know what happens after death, which is, there's no more kind of caregiving burden related to the ADHD patient. And before we're kind of thinking about, we're trying to leverage sort of the known progression and stages of the disease. We don't know exactly when it happens, but we know that kind of, it progresses gradually. Diagnosis for us, to think about it, we think it's trickier because we don't know exactly in what stage the diagnosis happens. So, the kind of the average trends are harder to think about. So for us, we just think that death is just a better defined event.
So I have a question for Yulia as well. So I think the mechanism question is really interesting because I would have thought it would be a caregiver burden story, but the fact that your stratifying analysis by nursing home stay found quite the opposite, which is that when the spouse had been in nursing home, it seems that the sort of the pre-trend is even sort of more prominent. I thought it was really interesting. And then you mentioned that for those when the spouse had been in nursing home, you combine both so it was like whether they were in nursing home at any point in time. So combining both sort of short stay, long stay. Did you try separating those? Because obviously whether they were just in nursing home for a brief period of time versus they've always been in there is quite different in terms of the caregiver burden implications. So have you kind of tried doing that? And yeah.
Yeah, that's a great point. Unfortunately, nursing home stays in our particular slice of the registry data are not well defined. So we've had to sort of do some imputation when we're thinking about. So our measure is ever spent any time in a nursing home, which is, and the way that it was recorded had changed over the time period. So it's hard to split it into anything that we think is sensible. And it's one piece of evidence. I wouldn't kind of rest everything kind of on that one split, in part because our measure of nursing home use is a little bit fuzzy.
Yeah, I don't know if you're able to do this using HRS Medicare linked data I'm sure there's a reason why you didn't use that data, but yeah, that'll be interesting.
Yeah, I mean, the broader point, I think, is, and this is where kind of the setting and the difference between two papers, and then the similarities between two papers, I think the first two papers are interesting. The companion paper where we look at spillovers on children show no kind of, we don't see any spillovers on education, or on labor supply, for example. And our interpretation is that there's not a lot of caregiving by children. And so a lot of the spillovers that we see are kind of what's unique to dementia rather than another debilitating disease that, might kind of, impact physical capability and ADLs, but not cognitive function. And so what we think is happening is roughly the same story here, where it's these spillovers that are much harder to compensate than, the time that it takes to take care of somebody is sort of this like mental, this relationship is eroding, you're having to, decision-making capabilities that, you're having to take over, and these big dramatic changes that are kind of going beyond the physical caregiving. I'd be curious, how you guys are thinking about that in the US context, but that's sort of where my head is going when I see those results.
So this is actually a question for both Yulia and Alden. In both of your cases, I'd sort of be curious to know how much of this is really ADRD versus other similar, or other diseases, whether similar or not. So Yulia, in the case, you said, does anybody have a good way to think about categorizing diseases? When Andrew and I were talking about this a little bit earlier, it's sort of like, it feels like the graph is like your spouse is sort of fractionally dying every year for like the preceding 5 years. And so with that in mind, you might imagine that like you could machine learn what the conditional unobservables probability of spousal mortality is given their observed health characteristics at a given point in time, and sort of ask how much of this loads on like the observable probability of death. So something like cancer, or really aggressive cancer, or whatever the appropriate codes are, looks like you're more certain this person's going to die in the next couple of years. For Alden, I guess I wonder, the MDS gives us a ton of information about the other types of like characteristics that people have. I wonder whether you could look at things like, oh, is it really about ADRD, or like could you, as a placebo, use something like somebody who's behaviorally difficult? Or is it resource intensity, and you can use something like a RUG score, like what exactly is it? Is it really ADRD specific, or is it something about the resource sharing?
We can't distinguish whether it's ADRD per se or something that's perfectly correlated with ADRD or positively correlated. We do look at CPS, which is like a measure of cognitive impairment, as well as activities of daily living, and we find qualitatively similar results. But in terms of implications for room assignment policies, it doesn't really matter whether it's ADRD or something correlated that's driving these effects.
No, that's an interesting suggestion. We can think about doing something like that, for sure. Thanks.
For Yulia, sorry, some of this discussion was making me, I guess, think a little bit about how, like how much of the time that it takes the person with ADRD to die is related to the caregiver, like how they're faring, right? And so like that seems like that could potentially be an issue for you, that like you're not necessarily picking up, like the patterns of what's happening with an exogenous event, like you're kind of maybe picking up basically like how the caregiver is like doing, and then that's causally relating to like how long it takes the person to die. I mean, maybe that would go in the opposite direction of what you find, and then when you have your nursing home results, if everything's loading on the nursing home, then maybe that's not, what's going on here. But I guess I was wondering if you've thought about like how to tease out basically that kind of essentially reverse causality.
I'm trying to think through. So your point is that, so I'm not claiming that the timing of mortality is exogenous. So just to be clear, like that point is well taken. It's, it can certainly be related to characteristics of the caregiver. So your point is that the mental health of the caregiver might kind of impact the timing of the mortality, and so that would. Maybe we should talk about this offline. I'm having a hard time thinking through what. Yeah.
I keep thinking about, especially the discussion of monitoring and stuff, that this isn't so much about that. What's unique to ADRD is loneliness and social isolation of the spouse. And it's very much in line with like death. So like this idea that what you see leading up to death is very different in ADRD because it's the social the isolation, the loneliness. And there's lots of stories about how that is key to living, right? And it links roommates too. It would be nice if there was some concrete measure and way of knowing that we'd seen isolation, a type of social isolation. And loneliness increasing for folks like that, both before their spouse dies and the roommate, some way of measuring that. And I don't know if there is any data like that.
That was a very comprehensive, really well blending 3 And liver, alcohol-associated liver disease mortality.
All right. Thank you so much to the organizers for inviting me to present this research. This is joint work with my colleagues Joseph Alejandro, Natalie Semetsky, Natalie Smith, and Christina Mayer at Pitt. So just to motivate this research, what I'm showing you over here on the left is trends in age and sex-adjusted alcohol-associated liver disease mortality rates in the US, going back to 1968 up through 2023. And so what you can basically see is that this is a condition with which we were making a lot of public health progress over time. So rates peaked in the 1970s, and then declined for about 30 years, started rebounding in the early 2000s, and then in the most recent year we have rates that actually exceed pre-1970s levels. And so this is also one of 3 deaths of despair alongside drug overdoses and suicides that a large body of work by Case and Deaton has documented have played really important roles in recent stagnation in life expectancy in the US, as well as growing disparities in longevity by educational attainment. And so just a really important public health issue. And what we were really interested in this paper is a puzzle, which is that this really occurred among widespread epidemiological evidence across most major surveys that drinking in the US has been relatively stable and even declining for many subgroups, such as younger adults and men in particular. And so what we do in this paper is try to understand what might explain this. And so since I don't have a lot of time, just at a very high level, different hypotheses that people talk about which could explain these trends. One is that people are drinking more in ways that could contribute to alcohol-associated liver disease. One hypothesis could be that the economy is really not working that well for people, leading them to use more drugs, drink more alcohol, and commit suicide. That's the kind of deaths of despair hypothesis of the epidemic. In addition, there could be commercial determinants. The last major time that alcohol taxes were raised in the US was 1990, so alcohol has become relatively cheap over time. Alcohol marketing, there's been some evidence that people have been more exposed to that over time. And then in addition, in the pandemic era, there was a pretty big spike in drinking that's been documented and could be contributing to these trends. And we're not going to focus on any of these in particular, but just as a whole, what any of these hypotheses would predict is that the rise in ALD should roughly track increases in harmful drinking and be highest where harmful drinking is increasing the most. An alternative hypothesis that's been increasingly discussed clinically but hasn't so much made its way into the demographic literature that's looking at mortality trends is that the amount of harm that's being done per drink is increasing in the US with increases in the rates of obesity as well as metabolic syndrome. And this is pretty well established in terms of a biological mechanism. And just to give you some brief clinical context, one way to think about it is that obesity and metabolic dysfunction independently promote the accumulation of fat in the liver as well as inflammation, which lowers the threshold which drinking can do irreparable harm and can contribute to death. And so the prediction here is that the rise in ALD should track increases in obesity and really be highest where obesity and heavy drinking are coinciding. And so next I'll just show you a couple descriptive trends before getting into our empirical design. And so this is trends in ALD mortality rates in the black line from the NCHS multiple cause of death files against trends in heavy drinking prevalence, which is drinking more than 2 drinks per day on average among men over the past 30 days, or drinking more than 1 drink per day among women. And you can see that that's relatively flat against the ALD mortality increase. There is a spike of about 25% during the COVID-19 pandemic period, but over this whole time series that has fallen by about 4.5%. You can also look at other measures of drinking, so binge drinking prevalence. An administrative measure would be alcohol consumption per capita as compiled via state tax records, as well as whether the people who are in that heavy drinking group are drinking more over time. And at most, you would see that those are increasing by on the order of something like 15 to 20%. And so it's pretty hard to explain this large rise in ALD mortality just from changes in drinking. On the other hand, what's increased a lot over time is the metabolic health among people who are reporting heavily drinking. And so this is using the same behavioral risk factor surveillance system data source, showing among people who report drinking heavily, what is the share that are also obese. and that has gone up by about 117% over this period, actually outpacing the increase in ALD mortality. If you look at severe obesity, so this is people who are both heavy drinkers and have a BMI of greater than 40, that's gone up by about 450%. It's increasing from a really small initial baseline. And you can also see similar trends in other measures of metabolic dysfunction, such as diagnosed diabetes among heavy drinkers. And so what we then do next is a descriptive exercise to just characterize what is the potential role of obesity in explaining these trends. And so we use 25 years of NCHS and behavioral risk factor surveillance system data, where we estimate a two-way fixed effects Poisson regression model, which relates alcohol, liver disease death rates in a state and year to three main terms. One is a drinking prevalence term, and we'll use heavy drinking prevalence for that. The second is an obesity prevalence term, and the third is the interaction between obesity and heavy drinking prevalence, and we can control for state and year fixed effects. Standard errors will be clustered on states. All of these measures will be age and sex adjusted, so we're taking out any age or sex composition effects. And the coefficients will be identified from within state shifts in prevalence of heavy drinking, obesity, and then their joint distribution. So this is just a non-parametric visualization of the underlying data. And so what we're doing here is we're residualizing state and year death rates, obesity prevalence, and heavy drinking prevalence, and then just plotting mean death rates over 4 quartiles of residualized obesity prevalence on the x-axis, and then heavy drinking prevalence on the y-axis. And what you can clearly see in this is that the harm is really concentrating in the periods where both obesity and heavy drinking prevalence are rising within states over time. This is the output from our regression model. So what I'm plotting here is the average marginal effect of a 1 percentage point increase in heavy drinking prevalence evaluated at different levels of obesity prevalence. And so this is quantifying that interaction term, where we're ranging the x-axis from 19%, which was essentially average obesity prevalence levels in 1999, up to 33%, which is average obesity prevalence levels in 2020-23. And so at 1999 levels, a 1 percentage point increase in heavy drinking prevalence would have been related to a pretty small and imprecisely estimated increase in ALD death rates. And then fast forward to 2020-23, and that's a much larger increase in ALD deaths from any given similar change in heavy drinking prevalence in the population. One way to think about these magnitudes is we do a decomposition exercise, which says how much of the rise in ALD deaths can be explained by rising obesity, holding drinking fixed, and then vice versa for drinking, holding obesity fixed. And about 50% of this increase is attributable to the rising obesity prevalence over time at the same drinking prevalence held constant in 1999. Lastly, a really important part of the deaths of despair literature is that we know that this cause of death and others are also really dramatically expanding by educational attainment. And so this first plot is just showing ALD mortality among people without a college degree or less than 4 years of college in the top red line, college graduates with 4+ years of college education in the blue line, and that's really, the gap is growing over time. And that also seems to reflect diverging metabolic risk as opposed to differences in drinking behaviors. And so the drinking difference has actually converged somewhat over time. The metabolic risk among heavy drinkers, you can see that it's increasing more for people with less than college educational attainment. But interestingly, that will still only explain about 28% of the increase among non-college graduates, whereas the obesity increase can explain virtually all of the increase among college graduates. And so this trend seems to be having a lot more harm on the lower educational attainment group in this case. All right, so just to wrap up and conclude, the main takeaway from this research is that rising obesity is raising the marginal harm of drinking, explaining a quantitatively important share of rising alcohol-associated liver disease deaths over time. And this really reframes an epidemic that's often viewed in behavioral terms as one that's also substantially metabolic in nature. And we think that this has really important implications for how we might most effectively address this problem. Thank you. I'm looking forward to questions.
Go right to questions from the audience. This is just an informational question. Can you drink alcohol while doing GLP-1s? Like, you know, forecasting what's happening in the future, can you drink alcohol and be on a GLP-1?
Yeah, you definitely can. Interesting, there's also some emerging research that GLP-1s may reduce cravings for alcohol in populations with alcohol use disorder. So you definitely can drink. You may want to drink less.
Have you tried this? It's still on. It says it claims it's on. That's better. Have you tried this stratified by age? So what's the age? What are the age groups here? What's the range?
So this is 15 or 18 plus, age and sex adjusted.
But going right up to older ages.
Yep. Yeah.
There's this other effect that Ellen Mira and Ralph Lawton, I don't know if, is Ralph, are you here? Do you want to talk a little bit about the age-specific effects of smoking, for example? Could that explain this? All right.
Yeah, we have this interesting finding, which is that in some forthcoming, hopefully soon, work, we're trying to show that a lot of the increase over time in the mortality risk associated with smoking is actually just population aging. And that's kind of hard to take account of heterogeneous effects within different age groups of risk factors like smoking or like obesity, for example, that could be kind of changing over time under the hood here. This is super interesting, but potentially we're trying to think through like how could you do this within as fine-grained age cells as you can to kind of enable yourself to look at those effects over time.
So we can definitely do that. I mean, in terms of like general trends by age, you see that they're falling really sharply for younger adults, and the ALD is increasing in that group as well. And then in middle ages, drinking is increasing a little bit more. ALD is kind of increasing even faster, but your question seems to be, is there heterogeneity in the underlying association between drinking and that?
It's surprising how little that age adjustment takes out.
Yeah. And so the suggestion would be to run the decomposition within fine-grained age groups.
Stratify by age.
Yeah, thanks.
Yeah, just to take a look. Also, because the age composition is changing as the baby boomers are kind of moving into, as the baby boomers are moving into sort of older age, so it's your, anyway, it's just a suggestion.
It's a great suggestion, thanks. Who's there?
Okay, yes, thank you. Just curious, can you do anything by race also on the trend, by race, ethnicity?
So we can, yeah.
Yeah, because
you
you did education and, it can further help you try to get at the different,
so
trends.
Definitely can. So one reason we haven't spliced it too much yet is we are using the state level behavioral risk factor surveillance system. So once you start to cut down into, drinking prevalence by state among specific race or age groups, it can get a little noisy, but I think we should try to push more there and perhaps using some other data sources to supplement.
I guess one way to describe what you're saying here, I think, is that just over time, the degree of comorbidity between alcohol use disorders and or problem drinking and obesity has changed. Is it are the regressions essentially a version of a decomposition in which you're saying imagine you had the same level of drinking, but you sort of reweighted the comorbidity profile so that it was more like the 1990s or something like that? I guess I'm thinking of DiNardo, Fortin, Lemieux style interpretation of inequality. Is that the right way to understand what you're showing?
That's conceptually what we're going
it's
for.
a different method, but
yeah. That's a great suggestion. Yeah. Thanks.
So there is a broad category, which is just all things metabolic, right?
Yes.
You can just have a death like that.
And I think that it's cool, it's clever, I like it's compelling, the sort of interaction with obesity. But I'd be curious just to see, like, are the metabolic deaths trending in lockstep with these deaths related to alcohol, right?
Yeah.
Like if a sort of first difference thing by geography, if that's doing the exact same thing, I find that to be even more compelling.
Yeah, so we've run that. It isn't in the slide because we just did it kind of recently, but essentially you can also look at liver disease deaths that are not alcohol related or that are not as alcohol related. So one would be cirrhosis, other would just be non-alcohol related hepatitis. And those have essentially increased by about the same amounts, by 20%. And if you run the decomposition on those, it more loads on the main obesity effect as opposed to the interaction with obesity and drinking, which would suggest that, you know, part of this is this underlying metabolic health trend as well. Thanks, yeah.
Great.
Thank you.
Well, thank you very much. So we've had 2 days of economics of aging papers, and this was the capstone. David Cutler is going to talk about the economics of chronic conditions, and Nicole Maestas will discuss afterwards. Yes. While we are transitioning slides, I also want to take this opportunity to thank Juliet Pepe, who's been fantastic at getting us through all this. So thanks very much.
As an organizer, I thank myself for putting this on the agenda. Actually, so a couple of things about this paper. One is this is joint work with two other people. One is Ralph Lawton, who you just met, who's a PhD student at Harvard. And then second is Maria Polyakova at Stanford. And Maria just was unable to be here today, but you should read nothing more into that than that she was unable to be here today. So this is not kind of the usual sort of paper. This paper arose in part because I guess in the past few years there's been a lot of emphasis on rising rates of chronic disease in the US and what can we do about that or what to make of that and how do we think about the economics, not just the medical component of that. So I think it was John Phillips had suggested, well, you know, couldn't some economists just kind of write a little bit about how we should think about that? And so we started to talk about this a little bit, and it sort of became more complicated than we had guessed. And so this paper is the result, and so you can tell us whether we're reading it all incorrectly or not, or whether there's more or less there. So that's where I want to go with this. So rather than presenting a lot of new results to try and summarize things for you, but first I realized that I'm the last thing between John Skinner and freedom. So I thought I would first say congratulations and thank you to John. If you ask Claude for his age, he's in his early 60s. He appears to be very active, at least if you judge by his CV, but he does have a chronic condition, and that is an inability to say no to things. So I think I will call it Skinneritis, which is when you're asked to do something, then you always agree to do it, and maybe we'll give him a six-pack to celebrate. So thank you, John. Thank you. And it's. And for a couple of years, John has asked me to help be one of the organizers of Summer Institute, which I very much enjoy. Okay, so let me start off. What is a chronic disease? So chronic disease, by definition, is a disease that lasts at least a year and requires ongoing medical attention and or limiting activities of daily living. So you'll see various statistics about the prevalence of chronic disease over time. And it turns out, actually, that even what you want to take of as the prevalence of chronic disease is a thing that's not completely well known. So you'll see, for example, that 2/3 of Americans have a chronic disease and that's rising over time. Actually depends on two particular things. So the chart on the right is showing you from a number of data sources that I'll tell you about in a little bit about chronic disease. So one question is, do you want to think of obesity as a chronic disease? Obesity without other consequences for things like high blood pressure, high cholesterol, or cardiovascular disease, or anything else. Turns out about 10 to 15% of the population is has obesity but no other condition, and that tends to be in kind of the younger to middle-aged adult population, so people age 35 or so, may have obesity but no other condition. And so that the sort of upper part and the lower part here has to do with that. And that also influences whether you think the rate of chronic disease in the population is rising, which is what happens because obesity is rising, or whether it's much flatter if you say, no, I don't want to consider that, just like I don't consider smoking a chronic disease, so if I'm going to not consider smoking a chronic disease, maybe I shouldn't consider obesity a chronic disease. So that's definitional, you can go either way, but that's going to influence things. The other thing that matters a lot is sometimes you see statistics that are not age and sex adjusted. So non-age and sex adjusted rates of chronic disease are rising a lot. That's not quite so surprising because the population is getting relatively older over time. If you were to say, what is the rate, let's say I don't count obesity by itself, and what is, I want to age and sex adjust the population, rates of chronic disease have actually been relatively flat, although still pretty high, about 45 to 50% of the population. And then, of course, if you age and sex adjust and you include obesity in that population, it's up about 10 percentage points or so. So two things that matter a lot are what you think about people who are obese and not have other conditions, although they likely will as they age and if they continue to be obese. And second is, do you want to age and sex adjust, which normally we do, but if you're just thinking about population trends, then perhaps you don't want to do that. So I want to tell you a little bit more. So first, we're going to tell you a little bit more about consolidated facts about levels and trends in chronic diseases from existing data sources. Then we'll tell you a little bit about some of the economic research on the causes and on the consequences of chronic disease. And then we'll conclude with some observations about data and a few other things as well. One of the things I'm going to say is that surprisingly, we actually understand much less about the causes and the consequences of chronic disease than you would guess we would. And that's a real problem, and it's both a problem because we then are unable to answer questions. It's actually something we can address because if you think about all the research that's gone into things like the impact of stuff on wages, economic and social conditions and so on, we ought to be able to do the same thing for the impact on disease burden and the impact of disease burden itself, and yet those are not subjects that we've spent a lot of time on. So let me start off telling you a little bit about the prevalence of chronic disease and its change. To start off, I want to note that there are a lot of conceptual problems in this. So most of the time we get survey data, so have you had various chronic conditions over time? And of course we miss the people who don't know or say they don't know about their condition, which actually turns out to be very big and changing over time. More people know about their condition now, so reported rates of prevalence are up a lot. Which conditions are chronic is also changing over time. We used to think of cancer as probably more acute, like you had cancer, you then got treated, and either you survived or didn't. There's now a lot in the way of ongoing medications, and so it turns what was an acute condition into a chronic condition. Sometimes we do the reverse. We turn chronic conditions into acute ones, like hepatitis C, and then we just sort of treat it and it's done, or cataracts are the same example. So a lot of the line between what is chronic and acute changes. Of course, survival patterns can also affect prevalence. Some conditions, the incidence is going down a lot, but survival with them is increasing so that people have the condition for much longer. We've done our best to try and measure things, so we have 3 different data sources. We use the National Health Interview Survey, which is all self-reports, so we have a lot of different self-reports measures there. We have NHANES data. We particularly want that because for risk factors that are not, people don't always tell you about, so things like high blood pressure and high cholesterol, but also a whole bunch of other things that one can measure in addition to a number of self-reports. And then because, not surprisingly with this set of authors, we're particularly interested in issues having to do with dementia and cognition. Oh dear, oops, did I do something?
You go on, it's just...
Well, now none of you get to see what I have here. There we go. Thank you so much. Thank you. We use the Health and Retirement Study to track dementia. So we've got a number of things ranging to about 13 or 14 categories here. We have some things for adults and some things for kids. There are basically 3 sources of data that we have. We have biological data. Those are good. I'll put them in good, though, because I'll put the good in a bit of parentheses because responses to the surveys that actually measure things are changing over time, and they're missing certain groups in the population, so they're probably less good than we would think. Then we have self-reports, and we've tried to divide the self-reports here into those that we think are well measured based on other literature that shows that they correspond to true disease prevalence, and then things for which there's mixed evidence on how well they're measured they are. And so we have a number of different things. Most of the big things that you'd think about are here. But I do want to note that we are missing a number of conditions that tend not to be asked about in various surveys. Autoimmune conditions are rarely asked about, a variety of different non-mood disorder psychiatric conditions. And then things like hearing impairment, vision loss, so sensory impairment is not often asked about in surveys, and things like chronic pain and sleep disorders and so on. Okay. So in order to show you some trends in different chronic diseases, we've divided them into different condition areas, and then I'm just going to plot kind of normalized trends in those condition areas over time, so what's happened to the rates of them. So let me start off here. So this is 100 is the first year that we measure it, so these are conditions that we've seen large increases in the prevalence of in the population. Grouped together similar sorts of things into something called metabolic and something called anemia. Both of those are rising a lot, so the way to interpret a number like 200 is it's a doubling of the rate. Okay, so that sort of shows you that for some of these conditions, and so this is kind of what you think about like an epidemic of chronic disease in the US you'd see here, and these are the two biggest conditions that you'd see it for. Interestingly, you do not see it for a lot of other conditions that you think of as relatively common, which have gone up a little bit, but not an enormous amount. Mental health conditions, kidney disease actually been fairly flat overall, musculoskeletal conditions, things like joint pain and soft tissue damage and so on, and then cancers, all are up a little bit, but nowhere near as up as one would have guessed. And then a number of things have actually fallen over time, including cardiovascular disease, and actually notice the line at the bottom here, which is dementia. So on an age and sex adjusted basis, rates of dementia are actually falling in the population. Because of the aging of the population, it's going up, but otherwise it would be going down. Our net conclusion is that not all chronic disease are rising, so you probably should not think about a chronic disease epidemic. You should think a little bit more about what's driving it and think in particular about different sorts of things. That was for adults. Let me just tell you a little bit more about kids. If you look at kids, you see the same sort of thing, which are some things are going up, ADHD and autism are going up, metabolic conditions and anemia, and then other things, particularly mental health conditions in kids are going down. One of the rather interesting things about children to show you is that reported rates of autism are going up and reported rates of ADHD are going up. Parental reports of behavioral problems in children are going down. So either there's more diagnosis of things and that's what we're picking up, or we're now diagnosing and treating so that fewer children actually do have behavioral problems. But you see, sort of part of this is that you see very, very different rates oftentimes among things that are self-reported relative to when you can actually see the underlying, when you get some sense of the underlying trends, observed trends. I don't want to say one is true or not. I just want to sort of point out that we have a lot of these disparities here and we should think about them. As you look at this list, the thing that strikes you is that obesity, stuff that's clearly related to obesity tends to be higher on the scale, and stuff that's clearly less clearly related to obesity is lower on the scale. Somewhat surprisingly, that's not the full explanation for what's going on. So if you just take these and you sort of regress, like, do you have a metabolic condition of some sort on obesity and smoking and a few other risk factors, and then you say what would have happened had rates of obesity and smoking stayed the same, you see that the lines are lower, so the dotted lines are the lines that take out changes in risk factors and behaviors over time. And those lines are lower. They're definitely going down in all cases, so both cardiovascular disease and metabolic conditions and so on are lower. But they don't get you actually to flat. And this was something that we kept sort of probing a fair amount. It gets you about 40% of the way there, but not the full way there. So there's something else that's going on. And just going to sort of bleed into my second issue, which is what are the causes of this? Because this is what you would have said at first. Oh, of course, the population is more obese, and so we have the characteristics associated with obesity. Whether that's because we need to know more than just current obesity levels, we need to know about the history of things, or whether, like what Travis was talking about, there's an interaction between a variety of different conditions that leads to different types of health impairment. I don't know the answer, but sort of partly along the way we accumulated more questions than we had answers, and so I'm going to dump all the questions on you. So that's going to lead me into the second category, which is the second thing I want to talk about, which are the economic causes of chronic disease, and then I'll turn to the consequences after that. And so we're going to mostly summarize the literature, and I'm not going to do this in the way of a typical literature review, like here's endless tables with endless studies, but to try and sort of cut through them and say, well, here are the things that clearly seem to be important, and then here are things that we would like to know more about or seem to be unimportant. The surprising thing to me is that even with an enormous medical literature, there's still a lot we cannot say. And there are actually a lot of risk factors that people talk about for which there's very little data on how they're related to chronic disease. So let me walk through that a little bit. What is known most clearly is on the behavioral side. So this is what I was just showing you, particularly the rise in obesity, where we can account for about 40% of some chronic disease trends, although we're wondering what some of the remainder is. Environmental exposure. There's actually very good evidence for things like pollution exposure through things like respiratory conditions and cardiovascular conditions and the impact there. Also through things like Alzheimer's disease and dementia. So we'll give a fair amount there. And then we get into things for which the literature is not particularly clear. So it came up a little bit earlier in the discussion of the nursing homes, loneliness and mental health issues. Postulated to have impacts on chronic disease, very little evidence on this at all. So if someone could think of a way to look at that, it would be great to see. Economic conditions, we've done an enormous amount about, how do economic conditions affect deaths of despair? How do they affect changes in wage distribution? How do they affect wealth? And how do they affect even mortality? And very little on how do they affect the prevalence of various chronic conditions, which are then going to sort of play a role for people going forward. Particularly, actually, and that's particularly important because like a lot of the mortality impacts we look at are short term, right? Like do people, if it's the midst of a great recession, do people die during the Great Recession? And that's really important. But a sort of equally important thing might be, by the way, do people stop taking their chronic disease medications and so therefore things get worse? And does that then have a long-term impact on their health for which there's very little evidence about that? And there's no reason why there couldn't be more evidence about that. It's just that we haven't quite done it. The last thing for which we have a little bit here is healthcare access and utilization. So it would be good if there was an impact here because we know how to influence healthcare access and to some extent utilization. There's not actually a lot of clear evidence here. Coverage improves treatment, but it's not clear that it affects the underlying rate of chronic disease in the first place. That is, there's very little that seeing a doctor does for your obesity, even though it does treat the high blood pressure that can be a consequence of that. So I want to come back to the overall summary here, which is we cannot explain most of the changes over time, which is kind of surprising to me. And it seems like we ought to be able to do that, just like we can try and explain things like wage changes and mortality changes over time. And here there's much, much less of a literature here. So one of the things we wanted to do was call out areas where we thought we could use more literature, and I think this would be pretty high on my list of areas to think about. I then want to talk about the consequences of chronic disease, and here I think, if anything, the literature is even less well developed. So I want to talk about a few different areas: individual human capital and labor markets, family spillovers, and then the health system and fiscal and macro consequences. And just to give you a preview of some of the themes here, again, because I don't want to go through endless amounts of studies. One is that the fiscal implications come from a lot of different directions. The medical spending is high. It's particularly high because chronic disease is high. Acute disease, there's not an enormous amount of time in which stuff is done, but chronic disease, think about people with dementia or Alzheimer's disease. That's what's very expensive. And so the medical spending implications are high, as are the retirement or things like disability, going on disability programs, or even things about economic growth are all likely to be affected by the population's health, both the number of people and the average health of people over time. In addition to that, that then implies that there may be long-run benefits, perhaps greater than the cost, for things that treat various chronic diseases. There's almost no evidence on the impact of treatment. So where there's some evidence on the impact of health on things like economic outcomes, very little that then says, by the way, if you treat the health impairment, you then have different health outcomes in a way that's either better or worse for society. There tends to be relatively limited evidence from the US, so there's much more evidence in developing countries, and there's evidence in kind of Scandinavian countries where you have a lot of linked data sets and you can pick up things like that. It was not surprising that some of the studies are about, that we saw are about other countries. There's no reason why we couldn't have that data here, and I think John Phillips was talking a little bit about some of the data stuff, so he's on my list of people to nag about this. And then I'll say that we tend to focus more on acute shocks and less on treatments. That is a lot of work on what happens to someone after they have X, and relatively little on how does living for 15 years with pain influence what happens. Just to give you a sense, that's superbly important in things like disability insurance, where what basically goes on over time is people are in pain, and then the economy gets bad and they lose their job, or they can't find work, and then they apply for disability insurance. There's nothing about an acute onset of new pain or that the pain got worse. It's just that somehow in that environment it's people can tolerate it less. Okay, so let me talk, how much time do I have left, John, by the way?
You have 7 minutes.
Okay, excellent, excellent. I think I'll probably be good. I'll be good there. Okay, so first talk about individual human capital and labor market outcomes. What you want to think about in terms of human capital are typically things that happen early in life and then how they affect things later on. So a couple of things you might think about there. One is mental health. Mental health impacts tend to be very big. That is, mental health impacts in children affect them later on in life. There's actually a little bit more recent increase on interest in things like childhood obesity and how it affects people in later in life. Those are kinds of conditions, but things like the sort of increase in reported ADHD and autism and so on, much less research on other things that affect kids later, that happen early in life and that would affect kids later in life. Also a lot of impact on labor supply. I told you a bit about disability insurance, which is a clear dimension of labor supply. It turns out you might think about impacts both on labor supply as well as on labor demand, and there's a literature on each of these. But the evidence does suggest large effects here of both chronic disease on both labor supply and on labor demand, all of which is going to be mediated by health and social insurance systems, so what happens in terms of ability to qualify for different kinds of programs, in terms of treatments for different kinds of programs, and how you get different kinds of treatments for different programs will be important, which means that as much as I love Denmark, I'd love to also see evidence on the United States, because it would be, the systems being different suggests that the effects of different kinds of policies could be different across different countries. No offense to people from Denmark, who I otherwise find to be relatively nice in general. Okay, so that's on that end. Families spill over, and again, there's some areas where there are very large impacts and other things where we would like to know much more. Very large impacts, caregiving is the biggest one, a very big one, and we saw that just a couple of minutes ago with the papers again on caring for people with Alzheimer's disease, and that turns out to be a large issue throughout the lifespan. Much less on things like family formation. So a lot of conditions, chronic diseases, you could imagine that would come up during childhood and young adults could influence family formation. They could also influence, of course, things like education, but number of children to have, whether one gets married, all sorts of other things like that. Very little understanding of these sorts of issues. Obesity, there have been a couple of papers on consequences of obesity for family formation, and that too is something that you'd like to know more, both about that and about things like, for example, the impact of GLP-1s, therefore, on family formation and on number of children and so on. Probably some of the biggest impacts are likely to be on the health system. So health systems are really set up more for acute conditions often than they are for chronic conditions. So they're very good at when something acute happens to you, where do you go? And they're less good at thinking, this is true across the globe in terms of then thinking about how to deal with chronic conditions. So the cost implications tend to be very big. If you ask what is the single biggest fiscal uncertainty in the United States, it would be the cost of medical care for the federal budget. It could cost the budget, it could help make the budget. So just like basic things like understanding what would lead to good outcomes and bad outcomes along those lines. And again, not just sort of understanding, but also then how could you influence things? What is the impact of various kinds of policies? Fragmented health insurance landscape makes it be very, very difficult to think about the health system here, because selection issues show up whenever you have a chronic condition that, if you have rheumatoid arthritis this year, the odds that you have it next year are approximately 100%. If you don't have it this year, the odds you have it next year are approximately 0%. Therefore, the health insurance system is not going to handle that well, because it knows very well who's going to have rheumatoid arthritis or not. So one of the things that has happened over time is push for more universal insurance coverage modes as chronic disease becomes bigger relative to acute disease, and that's not surprising. And then you get into all sorts of issues about stability of health insurance systems. And so, how do these systems adapt to rising chronic disease levels, and is that going to be, basically what's the end point if things become so predictable that essentially all the conditions that we have become chronic in some way because we figure out how to treat them on an acute basis, and how do you design a health system with that in line are all really important issues. Let me touch very briefly on some of the physical and macro consequences. This is a little bit tangential to my particular work, but I do think it's important. Likely to have outside impacts here, although the effects are in lots of different directions. So for example, the impact of chronic diseases on disability and Medicare and Medicaid, or on Social Security and Medicare and Medicaid, can work in different directions. So some things make people sicker earlier and lead to more medical spending, but less Social Security payout, and some things do the opposite, so the balance between those, so in some sense, they're a little bit of insurance against each other. And we saw, particularly yesterday, a little bit of discussion about some of the insurance issues, which I put in this category. And then finally, I want to think about some things, prevention as, if you will, a form of savings. That is, if I can prevent obesity or Alzheimer's disease from happening at younger ages until they occur at a later age, then I've kind of saved myself some money for the future, which I can then save up and use in the future. So this is going to interact with overall budgetary consequences and things. Just to give you an example of how big this can be, the US sort of rode a demographic wave in the past 30 years or so. We didn't have to build any schools because we had a sort of baby bust. So we saved ourselves a lot of money from not doing that, and now we have the consequence of older people we have to think about. Fortunately, many of them are in better health than they used to be, but they're still, we still sort of got that benefit, and so you can think about these big fiscal consequences that way. In terms of the overall consequences, there are a lot of things we know. I do want to come back again just to sort of stress where we were here, which is that, we know a lot of these impacts. What we don't tend to know are things about the impacts of particular kinds of treatment. And we're often, and because some of these will be specific to the context, to the setting, I'd love to see more in US and that looks at different kinds of settings from the US and elsewhere. Okay, so final couple of points. One is for data needs, and I've said some of this, but I think it's worth sort of bringing this out some. One is we want to link health surveys with socioeconomic outcome data. So just as we've linked census data with tax data and a variety of different things like that, there's no reason why we couldn't link electronic medical record data or other health data with other kinds of economic outcomes, so we can look at the things like what are the longer term consequences of having particular kinds of chronic disease and or receiving particular kinds of treatments for them. So that's just a kind of data establishment thing that I think we would really benefit from a lot. We also don't use EMR data enough. Sometimes we measure things like, does the person have X disease? Do they have diabetes? Diabetes rates have soared. If you look at electronic medical record data, a lot of that is being just over the line. So like you go from, if the cutoff is 6.5, you go from 6.4 to 6.6. And it's true that is over the line, but the underlying risk is continuous, not discrete. And so knowing about detailed values will really be very good. So, in an AI-driven area, you can imagine AI will find the one day where your blood sugar was 6.6, and therefore you will then be diabetic forever and stuff like that. No presentation here can not mention AI at least once. And then finally, many behaviors and risks are actually not systematically tracked. So if you come back to things like the loneliness, mental health, we do track some. Loneliness, sleep, stress, meaningful social interactions are all things that, like if you pick up your typical book on aging, it'll say, really important that you deal with it. And we almost never ask about it, and it's almost never in our surveys, and we almost never relate it to any kinds of outcomes. Okay, so here's my summary, which is that chronic disease prevalence is, in some cases, rising rapidly, particularly with isolated obesity, but actually not always rising as rapidly as we had thought. Certainly the prevalence is going up because of aging, but sometimes I want to control for that. We absolutely do not fully know how to explain the trends, which kind of shocks me that we can't do that. Chronic disease has widespread and large impacts on families, government, and the economy, and so therefore thinking about things like how do interventions affect those, I think will be really valuable. And then finally, we could do a much better job with data and analytic methodology than we do. So that's a little bit of a summary, and hopefully that'll spark, as I say, not a lot of original research here, but hopefully that will spark some thoughts in people about where to go. Thank you.
I'm going to try not to mention AI. Exactly. I know. I'm not sure it really saved me any time on my slides, I got to say. Though they look really nice. All right. Well, this is just a terrific paper. And if you have ever tried to assemble these data yourselves to monitor population trends in a way that you can see where increases in the prevalence of chronic disease are occurring, and some conditions relative to others, age-adjusted or not. This has just been a tremendous amount of work, and I applaud the authors on creating a resource for the field in this paper that puts all of this in one place. This was a tremendous amount of work. I just find it astounding that nearly 2/3 of Americans live with a chronic disease today. And I think this really is kind of the main takeaway from the paper as far as the overall prevalence goes. I would tend to include obesity in that. That's the kind of crude obesity inclusive share in 2024. That's just a very, very high number. Now, it's true that the age-adjusted prevalence is flat if you exclude obesity, but it rises because of obesity. I think my favorite figure in the whole paper is this one. You can just stare at it all day. And it really just shows the complexity of this area with trends that diverge across body systems in ways that are just easy to lose track of and have wildly different implications for various domains that we might care about. Metabolic conditions and mental health conditions have been rising, pulmonary conditions and dementia falling, and cardiovascular disease declining recently. The declining, the progress on dementia here, I thought just was worth mentioning again. This is kind of easy to miss amid rising absolute numbers of people with dementia and rising costs due to population aging, but we have made progress in that the prevalence is declining. The anemia in this picture was puzzling to me, and it raises, so this is, right up there with metabolic conditions, a very high increase, and it raises, I think, just a conceptual issue around what is a disease and what is maybe a marker of other diseases. And that is, kind of gets at part of why some people would say don't include obesity. Do include it. I would tend to favor including it. So as David said, the causes literature really does run far ahead of the consequences literature. And that alone, I think, presents lots of opportunities for economics research, and David gave a very nice review of the causes, looking at everything from behavioral factors to health insurance to exposures that are occupational or environmental and social determinants. On the consequences side, of course, we're interested in human capital and labor markets, effects on families beyond just the employment of people doing the caregiving, healthcare systems, insurance design, and of course, I think these questions of aggregate productivity and growth are also really, really interesting to trace out how these effects might affect our economy going forward. Many high-yield opportunities are here, and I've just gathered them up in the paper with some little more words around them to kind of give you some of the research ideas that come out in the paper where they're sort of ripe for more attention from economists. These include, on the causes side, really trying to untangle the true incidence of a disease from shifts in diagnosis or awareness, diagnosis criteria, and then these shifts in survival that change who lives long with the disease. The work environment, how have changes in the work environment contributed to the prevalence of certain chronic diseases? And the environment's role in chronic disease development, not just as something that exacerbates existing conditions, but as something that causes or, on the other side, maybe ameliorates certain conditions. On the consequences front, I think mechanisms linking chronic disease to labor market outcomes is a really ripe area and something I've been working on. I'll show you a little bit about that in a moment. But there are also many opportunities around understanding the fuller welfare costs of family caregiving. There are really interesting questions here around paying for and ensuring care, not just as the conditions become long-lasting and forecastable, but also as they become curable, and where that cure might cost a lot of money, and the entity that pays for the cure doesn't get to reap the savings or benefits in the future. There are some really, really interesting opportunities here, I think, for economists to inform how we think about these questions. And then, of course, on some cross-cutting issues that come out in the paper are how, chronic diseases, their signature is that they tend to be slow developing conditions, and that is just not good for an RD design, for example. And so we do need more attention to new methods or creative research designs that can start teasing out the effects of these slower moving conditions. I second the authors' call for better data that link health and economic outcomes at the individual level. But new data is definitely something that could help us make a lot of progress on many of these questions. And of course, how do we anticipate how treatment innovation can reshape what's chronic, what's acute, and the like. So I wanted to just spend a little more time on this labor market mechanism as an area of consequence that just illustrates how much we maybe don't know about how these mechanisms work. How does chronic disease affect labor market outcomes? And what I'm showing here is a picture from work I've done with Kathleen Mullen, Bastian Ravestein, and Haley Clark, and we published this in PNAS last year, where we had to go collect new data in order to understand the prevalence of work-related functional limitations in the population. And we looked at the workforce in particular here. And just like the very high prevalence of chronic disease, you also see very high prevalence of functional limitations among people who are working. And so we had about 100 measures of functional ability where we asked people to report on their limitations in any of these activities. And the activities they all relate to particular job requirements in the economy, and jobs and occupations in the economy. And so what you're looking at here is just a variety of domains. So this is just kind of an aggregation of the 100 measures into the different body systems and areas that people report one or more limitations in. And they range from, the top one is limitations in your upper body strength or your torso's range of motion, limitations in sitting, down to mobility, all the way down to sensory limitations at the bottom. And so what we do see here is that more people report functional limitations than actually report diagnosed conditions. And this can suggest that either earlier illnesses perhaps linger in their effects, or functional limitations could be signals of something that's not yet diagnosed. But either way, the diagnosis-based read, you might need some additional information in order to understand that mechanism from the disease to labor market impacts. We associated the functional limitations with chronic diseases. And what you're seeing here is take the top line. So you're looking at diseases that are ranked in terms of their impact on the population, the amount of functional limitation that they impose upon the workforce. And the number one is mental illness. And you see that in our data, we see 27% of workers report a mental illness. The marginal association with increased limitations is 2.7 limitations per worker, and you aggregate that for a total impact per 100 workers among those 100 workers, you'll see 74 limitations collectively, and then you just rank them. And interestingly, diabetes and obesity kind of show up near the bottom of this list. So remember, this is the workforce, not the population. So even though diabetes and obesity might be rising fastest, and in fact, in our data, we see that 18% of workers have diabetes or obesity. The additional limitations are relatively few, only 0.7 per worker, so the impact on the workforce is lower. I think cardiovascular disease, the heart disease, is also kind of a very interesting one. It's incredibly impactful with a marginal association of 15 additional limitations, but relatively few workers have heart disease because presumably they have had to, that the severity of the disease pushes them out of the workforce, okay? And this, of course, brings us into connections with the DI system and the like. Okay. You know, the last thing I'll note, and this is just kind of, you know, another angle on this, where we compared functional limitations reported by workers in different occupations, and you tend to see that workers in essential and non-teleworkable occupations, that is, like parts of the economy that are less flexible, have higher functional limitations than those in other parts of the economy. And I think we saw evidence of this during the COVID health shock, where many essential workers had limitations that did not enable them to risk exposure to the public, for example. I'll close with just three suggestions to build on all of this. And on the causes front, I thought that we could perhaps, as a field, benefit from a common yardstick for comparing the causal factors. And I kept thinking about something like an MVPF for health, so that we could track, you know, and compare prevention dollars across, you know, for various diseases across these different behavioral, environmental, and social determinant channels. On consequences, I think the work we've done around the labor market agenda so far, and there's so much more to do here, would suggest a focus on mental illness and musculoskeletal disease, perhaps, rather than metabolic conditions. And I think it's just no coincidence that these two have also been the big drivers of DI growth over time. And then on methods and data, boy, I wish we had Nabanita's data from Denmark. And you know, it's you know, you might say, well, we have the HRS, but I would kind of gently push back and say that the HRS has invested heavily in health-related measures in the last decade or so, and I would love to see kind of a resurgence of the work side of the HRS, where we would have more detail about working conditions and work-related health measures that would allow us to get more purchase on some of these questions about labor force consequences, which of course also affect aggregate productivity in the economy and the like. Better methods, better data. It's hard not to call for that, but I do think we need to make some progress on this data front to make progress on understanding both causes and consequences. So thank you.
Thank you. So I agree with everything that Nicole said. Just to pick up on one theme very briefly, which is the limitations are associated with the kind of symptoms and impairments, not with the disease label. And so at one level, the disease label is immaterial, but it's of course important in then leading to those. But there's not a one-to-one correspondence between disease labels and symptoms and impairments, including because some things may not be impairing or because we have treatments or whatever. So that whole process is just really super important. But let me just open it up then. Mike.
Yeah, here to Nicole's suggestion about more labor market stuff on the HRS. I'll see what I can do. But it may be that we're going to have to survey people every year rather than every 2 years. We're already up to 95 minutes on survey or more. My main question though is on cohort effects. Most of what you presented was basically time trend type things. And I motivated that by looking at health trends in the oldest part of the HRS, where those cohorts were born during a time of favorable economic conditions and increasingly favorable economic conditions after World War II, compared to the younger cohorts where we see worsening health cohort to cohort. So it's kind of a twist in what is happening, and so it's clear it's not a time trend, possibly time trend plus cohort effects, but the cohort effects are strong. How does that fit in with what you're thinking about overall population health?
Yeah, so of course we cannot differentiate age period and cohort effects since they're perfectly collinear. We can potentially learn a little bit about it with some international data if we have folks in different countries from the same cohort who may have experienced different time trends and different things. But fundamentally, you have to make an assumption about one or the other. Here I was just showing you the time trends, but you're correct, those could very well be cohort effects, and there are a couple of papers that try and make that point. I guess trying to tell those apart is, I mean, really quite interesting, and it relates to some of the literature on the impact of early life factors later on in life. To what extent is what happens to one as a child or a young adult then related to what happens going forward? One of the interesting things about all of this is that things like, for example, education is strongly associated with cognition later in life. You know, do you have a college degree? And that appears to be causal in the sense that if you instrument for education, it seems to have a causal impact. Not, I presume, because of what you learn, but because of other things associated with it. So that does suggest the cohort issues may be important. And I guess my own sense is we should try and focus in on some of what those cohort factors could be, along with some of what the time series factors could be, and really try and identify both of them well, and then come back and say which one looks like it's more important.
Just one follow-up, that those chronic conditions that are particularly associated with old age, and we see how the prevalence is at that age and how it changes with aging, may be quite different from the prevalence when those younger cohorts reach those ages who right now are worse in worse health.
And obesity is a classic example where people who are 60 and are obese now have been obese longer than people who were 60 and were obese. So there may be a consequence of having a lifetime history of something different from a current value of it. Tim.
I just wanted to emphasize and add additional motivation for one of the points you made, which is that we just don't have a lot of great work of the effects of treatments on a lot of things, including spending. And the additional motivation I want to add is that, so traditionally CBO has not been willing to include savings from treatment, increased access to treatment when they're scoring bills that might increase access to Sovaldi or something. But more recently, they've become more willing to do this and have started to develop kind of micro-simulation models that would allow them to do this, with the specific case of Hep C being the first kind of test trial balloon there. But they want to apply this to more things, but there's just not evidence to use. And in this world where you can only pass budget neutral legislation, this is very impactful, because that means that this evidence, if it does exist, this policies that would increase access to treatment become pay-fors and much more likely to happen. And so just want to say to the group that if you want your research to have impact, this is an area where they want it right now, and will put it to use very quickly if you can find ways to estimate the effects of treatments for chronic conditions on federal spending in particular.
I will say the same is, so thank you for that. I will say the same is true about state policy too. States are doing a lot of things around, for example, treatment of people with intellectual disabilities or people who are frail in various ways, and they're spending state dollars on that, and now the federal government is cutting back, and so many of them are thinking about cutting back on that. And if they had a sense that actually cutting back on that would cost them $1.25 for every dollar raised because of the impacts on labor supply of people who then have to leave work to care for them or something like that, that would make a huge difference in what was going on. Just like it would at the federal level. So there are all sorts of ways in which knowing the answer to that could have a big impact.
Yeah, thanks for this. I have a question about how you think about prevalence trends, like the age-adjusted trends, in light of increases in longevity. So if you see something flat, like for dementia, so age-adjusted rates are kind of flat, does that mean that as people live longer, they're actually living more years of their life with dementia, and kind of how does that affect the interpretation of some of these things that may be declining on an age-adjusted basis, but people are living longer?
So you can't tell that from here, and you're correct to ask about that. So in the course of doing this, that issue came up. So I'd done the calculation with a former student of mine, Graham Peterson, where we said, what's happened to years lived at age 65 in total, and of those years, what's happened to the years lived with a disability and years lived without a disability? And it turns out that this decline is sufficiently big that it exactly matches the additional years, so that the average person is living, call it 1.5 to 2 more years at age 65, and 100% of that is without dementia, excuse me. So that the years in dementia are basically just completely flat because you're living longer, but as you say, each year has a lower probability.
So like the cumulative number of years that a human expects to live with dementia has kind of remained flat over this period, even
That's
as
correct.
the age-adjusted rate goes down. Okay.
Even though people are living longer, because at each age, people are less likely. Now, that didn't have to be, and you're correct, you can't read that just from this. Layla.
More question, but do you have any idea what's going on with anemia? It's really striking on this picture.
So it's a good thing I have a co-author who has 2 years of medical school. And so I'm going to turn, why don't we pass Ralph a microphone?
Yeah, we can round up to 4 for this one.
And is Dave Chance still here? No, I could he owes me a favor or two, so I could call him up.
We had the same question. We looked at this and we tried to poke it a bunch of different ways. Our first instinct was that there's kind of background inflammatory changes that can lead to changes in anemia, but that doesn't really map out to the story. Like a lot of the inflammatory markers are down over this period. We thought it might be obesity, like obesity could be kind of driving a bit of this, but even within, we see the same actual change within each like normal weight, overweight, obese category. That's not driving it either. Given just the common prevalences of like the various anemias, like it's probably something dietary, right? Like it'd be hard to say like cancer, as Nicole was saying, can kind of lead to this stuff too, but cancer prevalence isn't up in a way that would lead to these big changes in anemia. So we can rule out a bunch of things, but it's hard to actually say what it is.
Might be dumb, this question. So if we use GBD data, what the picture may look like?
If we use, I'm sorry?
GBD, Global Burden of Disease, which measures daily and other.
That's a very good question. So I would guess the global burden of disease data, like for the elderly, would probably say the same thing that we were just talking about in terms of most of the years lived have been pretty healthy years. One of the intriguing things, and it comes back a little bit to my Kurt's comment about cohort effects, is that these health trends are not necessarily the same at all ages. And in particular, like rates of heart disease, you see going down here. At some other ages, for example, deaths from heart disease are going up in certain segments of the population, particularly population with fewer years of education. So I don't know what it would look like for the population as a whole, because I know that for some things the trends differ demographically. The elderly population is in some sense doing much better than others, and child survival, infant and child survival is improving. So those are 2 age groups where things are going very well, and in the middle things are going much less well. Okay, thank you all so much.
Thank you, everybody, and thanks to all the presenters, the discussants, and just a note to keep sending papers in. There are lots of aging-related NBR meetings coming up, and love to see more and more presentations. So, any last words or? All right, we're adjourned. Thank you.